Hello guys. Hello guys. Good morning. Good morning everyone. Good morning everyone. Hope you can see me. Good morning. Good morning. So today is our last day. Today is our breakup day. Okay. Um. So let's complete today. General physiology. Okay. General physiology we have to complete. In general physiology, what are the topics we are going to complete? Let me write here. Let me share my screen fast. 3, 2, 1. Okay. Let me share my screen. So in general physiology, the topics which I want you to know. Let me tell you how many questions will come from the general physiology topics. Okay. So in general physiology, from where you can expect the questions. Okay, from which topics you can expect the questions, sir. One is cell membrane. Okay. From cell membrane, you can expect the questions. Second thing, cytoskeleton. Third topic is cell membrane, cytoskeleton, cellular transport. Body fluids. Next, nerve physiology. Nerve physiology is like, no, it's just a two-page topic. Nerve physiology and muscle physiology. Okay, nerve physiology and muscle physiology. So from general physiology, see, these days, especially in June attempt, okay, especially in June attempt, most of the questions are going to be like clinical, right? So general physiology, importance, okay, give least importance to the general physiology. Okay, see, according to the previous patterns I am talking, okay, first go with the systemic physiology, because systemic physiology can be highly integrated with the medicine patho, pharma and surgery. So general physiology give less importance, because for example in the last attempt, okay, 20 days back, do you know how many questions came from the general physiology? So general physiology say two questions came, and that too one question, like, you know what is one question? Gluts. Okay, glucose transporter type 4. So that glucose transporter type 4 transport, cellular transport, one question will come 100%. That one question on the gluts and SGLTs will be there. There is no doubt about that. Okay, and one question came from the cytoskeleton. Okay, dynein. So dynein is a. So two questions will come from the general physiology. That's it. Okay, from all these topics, from all the 6 topics, you can expect two questions. So I said you clearly. Okay, I have said you clearly. Now, without any further late. Okay, without any further late. Now today, let's start with cell membranes. Okay, now let's take the heading cell membrane. Come on, guys. Right, cell membrane. Let's see the topic cell membrane in your book. This is there. Cell membrane topic is there. Just once open the topic cell membrane. Now in cell membrane, right, one by one, right. So let me check everything is clear or not. Is like, am I sharing the screen? If you have any doubt, let me check, cross check once. We're having network issue. Okay, chalo. So your cell membrane composition. First thing, composition. You are having this cell membrane, right? All your cells are having your cell membrane. All your cells are having the cell membrane. So what is the composition of the cell membrane? Sir, in your cell membrane, proteins are of highest percentage. Okay, proteins, how much percent? 55% of your cell membrane is proteins. 55% of the cell membrane is proteins. Okay, this is highest percentage. Next, lipids. Okay, lipids almost approximately 45%. Okay, approximately lipids are 45%. Okay, sir. Next, third, carbohydrates. Okay, so these are the approximate values. Okay, carbohydrates will be somewhere between approximately 3 to 5%. These are all approximate values. Okay, so composition, they will ask you repeatedly ask question. The major component of the cell membrane is proteins. Okay, now some important points which I want you to know. Sir, proteins are maximum. Okay, good. Okay, but where do you have, in which cell membrane do you have maximum? Of course, everywhere proteins are maximum. Okay, but maximum proteins are present where? In inner mitochondrial membrane. That's also cell membrane. Inner mitochondrial membrane is also made up of phospholipids. It's also membrane, right? So maximum proteins are present in inner mitochondrial membrane. It's also membrane. So this inner mitochondrial membrane have the maximum amount of proteins. Okay. If you don't find this answer, this is the best answer. If you don't find that, then the next best answer is presynaptic membrane. Okay. So presynaptic membrane, presynaptic membrane, between the neurons, this is one neuron and this is the other neuron. In between them, there is a gap called as a synapse. Okay. This is a presynaptic membrane, this presynaptic membrane. So it have a lot of proteins. Okay. Next, one exception. Sir, everywhere proteins are maximum. But in which cell membrane lipids are more? So that is exception. Okay. What is that? In which cell membrane lipids are greater than proteins? Okay. Actually, in that cell membrane, lipids are 80%. Proteins are just only 20%. Okay. What is that cell membrane? That is Schwann cell membrane. Okay, that is Schwann cell membrane. Okay, let me write in a different color. Let me take Schwann cell membrane. So I believe you know about the Schwann cells. Sir, what are Schwann cells? Schwann cells, sir. What are the Schwann cell? It causes myelination. Okay, myelin sheath. It produces the myelin sheath. Okay, Schwann cells are the cells which produces the myelin sheath. Okay, they cause myelination. Around what? Around the peripheral nervous system. Schwann cells, they produce the myelin sheath around the peripheral nervous system, because around the central nervous system neurons, it's the oligodendrocytes produce myelination. But see, the Schwann cell membrane may, there are more lipids. Okay, there are more lipids. How much? 80% lipids. Okay. Now let's discuss about lipids. Okay, now one important point I want you to know about the lipid. Sir, which type of lipids are there? So there are, for example, let me write here itself. In the cell membrane, there are different types of lipids like phospholipids. Okay, there are phospholipids. Again, it will come, don't forget. Okay, phospholipids are there. Okay, glycolipids. Phospholipid means a lipid attached with a phosphate group. Glycolipid means a lipid attached with a sugar molecule, or the glyco means the carbohydrate molecule. Okay. Next, phospholipids, glycolipids, cholesterol. Now, one question, this is the question which I want you to know. Are cell membrane mein lipids are there, 45% lipids are there. Okay, which type of lipids are there? Phospholipids, glycolipids, cholesterol is there. But what is the exception? What is the not exception? What is the important point? Note is, so triglycerides are absent in lipids. Okay, so triglycerides are the lipids which are absent in cell membrane. So triglycerides. Okay, triglycerides are absent in cell membrane. Okay. So this is a point which I want you to know. Next, carbohydrate. One more thing. One more important point is okay. Let me write here itself. Sir, phospholipids are there? No. Which lipids are more? Phospholipids are maximum. What is the major lipid? This is the question which was asked in the exams. Which lipids are maximum in the cell membrane? Which lipids are maximum? Phospholipids are maximum. Okay. Next, PYQ is cholesterol का function क्या है? Okay, cholesterol is there in the cell membrane, sir. Okay, what is it doing? Sir, it determines the fluidity. Okay, it determines the fluidity, means flexibility of the cell membrane. So whenever flexibility is less, it increases the flexibility. Whenever there is more flexibility, it decreases the flexibility. So cholesterol, it alters the cell membrane fluidity or flexibility. Cell membrane fluidity is very much important for the process of exocytosis and endocytosis. For the process of exocytosis and endocytosis, you require the cell membrane flexibility and or fluidity. So the important point is cholesterol, it acts as what? Fluidity. In a simple word, fluidity means flexibility, fluidity buffer. Okay, it manages the fluidity. Okay, it maintains the fluidity. So question in FMG, cholesterol is a fluidity buffer. Okay. Next, first, let's discuss about proteins. Okay, we have written here proteins, right? Proteins, 55% of the cell membrane is proteins. First, now let's discuss about the proteins. Let's discuss about the lipids later. Okay, first take the heading proteins. One more thing before going further. In one of the FMG exam, this question was also there. Sir, proteins are more, we know it. And lipids are next, like 45%, proteins are 55%. In one exam, protein to lipid ratio. Okay, so the protein to lipid ratio in a cell membrane. Yes, of course, I know, sir. It is 55%. Proteins are more and lipids are 45%. But in one of the FMG exam, they have asked protein to lipid ratio. How much? In that exam, they have given 1:1%, almost 1:1%. Okay, remember such kind of question is also there. So protein to lipid ratio in a cell membrane. The question which was asked in the exam is the protein to protein weight to lipid weight in the cell membrane is almost 1:1. Okay, just remember that. Next, take the heading proteins. Proteins in cell membrane. Now, how many types of proteins are there? Look at here. Let me take it. Here it is not that clear, but anyway, in your book, image is there. Sir, here is a cell membrane. There is a cell membrane. Here is the cell membrane. Now, in cell membrane, see, there is this one protein molecule. See, this is the lipids. These are the lipids. Okay, these are the lipids. These are all the phospholipids. Okay, these are all the phospholipids. Now, in this phospholipids, in the here, what are these things? These are proteins. So, how many types of proteins are there? See, there is one protein which is going through the cell membrane from in to out. Okay, so such kind of proteins are called as first type of protein. Now I'm writing here. Such kind of proteins are called as integral proteins. Integral proteins. So integral proteins means what? So those proteins which are there throughout the cell membrane. Okay, throughout the cell membrane they are there. So these integral proteins, the one type of integral protein is a transmembrane protein. Trans means throughout. Trans membrane protein. Okay, it's transmembrane protein. Transmembrane means also throughout. Okay, it's a protein which is extending, it's spanning from outside to the inside. Okay, from extracellular side to the intracellular side. They are called as the integral proteins, or you can also just say them as transmembrane proteins. Next type, see, there are proteins which are just present either inside or you can have it outside. If a protein is just attached to the cell membrane, to either inside or outside. Okay, so they are called as peripheral proteins. Okay, they are called as what? Peripheral proteins. For example, see, there is a protein which is just attached towards one side. So such proteins are called as peripheral proteins. peripheral proteins. And last type of proteins, which are actually having bonds, covalent bonds, tightly attached with the lipids, okay, they are called as lipid. Okay, these are proteins which are having attachment, covalent bonds with the lipids. Okay, so they are called as lipid anchored proteins. Okay, so mainly the proteins in the cell membrane are divided into three types: integral proteins, peripheral proteins, lipid anchored proteins. Three types of proteins are there. Now, in your exam, what they can ask you is, can you tell me example of integral protein? Can you tell me example of an integral protein? Sir, have you ever heard about this sodium potassium ATPase? Okay, sodium potassium ATPase, what it will do? Sir, sodium potassium ATPase, it transport the substances, right? Sodium potassium ATPase, they transport the substances. So 3 sodium out, 2 potassium in. Okay, so what is that? It's an example of transmembrane protein. So right, examples are important. Sodium, potassium, ATPase. Or for that matter, any channels, wherever you see the word channels, any channel, sodium chloride channel, sodium potassium channel, like potassium channel, sodium channel, voltage gated calcium channel, all channels. Okay, channels are examples of integral protein, sodium potassium ATPase, integral protein. Sir, have you ever seen such things? Sir, imagine this is the cell membrane. So there is this thing, there is a receptor, which is going to be something like this. In pharmacology, it will be coming. Okay, so there is a receptor, which is a protein actually. It is spanning throughout the cell membrane, something like this. Means there is this protein outside as well as this protein is present inside the cell membrane. Can you tell me what is this protein? Or what is this receptor? This is called as a 7-pass receptor or serpentine receptor. Okay, first example. Second, 7. This is also question 7-pass receptors or serpentine receptors, which are your beta receptors, like beta 1 adrenergic receptors, beta 2 adrenergic receptors. They're all serpentine receptors. Okay, they're all serpentine receptors, or you can also call them as G protein coupled receptors. GPCR, G protein coupled receptors. These are all the same things. Okay, so all these are examples of integral protein. They are present throughout the cell membrane. That is important. Now, what are peripheral proteins? You know, peripheral proteins, either they are present inside or outside. Now, what are the examples of peripheral proteins? Okay, examples of peripheral proteins. One example is spectrin. Okay, spectrin and chirin. Okay, spectrin and chirin. And dystrophin. Okay, spectrin and chirin and dystrophin. Spectrin and chirin, dystrophin, these are examples of peripheral proteins. They are only present on one side of the cell membrane. The spectrin and ankyrin, where they are mainly present, sir? They are mainly present in RBC. They are mainly present where? In the RBC. This spectrin, because of these two proteins, spectrin and ankyrin, RBC is having which shape? Biconcave shape. Okay, the biconcave shape, you know, RBC is having this biconcave shape. And that biconcave shape is because of these two proteins called as a spectrin and ankyrin. The spectrin and ankyrin valla RBC is having that biconcave shape. Now, look, for example, sir, the spectrin, if it is defective, okay, let me write here. So, spectrin is mutated. Okay, spectrin mutation. Now that spectrin protein is not properly formed. So, do you think RBCs are going to retain their biconcave shape? No, that will cause elliptical RBCs. That is called as hereditary elliptocytosis. That will lead to elliptical shaped RBCs, hereditary elliptocytosis. If ankyrin is defective, okay, if ankyrin, if it is mutated, okay, ankyrin gene is mutated, that will cause hereditary, okay, hereditary spherocytosis, spherical RBCs. Okay, spherical shaped RBCs, round shaped RBCs. Okay, done, sir. Now, where is this dystrophin present then? Sir, spectrin and ankyrin, they are present mainly in the RBC cell membrane. Okay, then where is this dystrophin present? So, dystrophin, it is present in skeletal muscles. Okay, skeletal muscle membrane. Okay, skeletal muscle membrane. The skeletal muscles have cell membrane. No, in that skeletal muscle membrane, dystrophin is present. Okay, dystrophin is present. Now, if this peripheral protein, they have asked repeatedly, dystrophin and dystrophin is not an integral protein. Dystrophin is a peripheral protein. It is present in the skeletal muscle membrane. Okay, skeletal muscle membrane. So, in our see, dystrophin is a protein, right? So definitely it should have a gene. So that is a dystrophin gene. So dystrophin gene. What is something special about the dystrophin gene? In our entire human genome, dystrophin gene is the largest gene. Means it have so many base pairs. Okay, nitrogen base pairs. It's having lots of base pairs. It's the largest gene. Dystrophin gene is the largest gene in the human genome. Okay. Now, what if this dystrophin is gone? Okay, listen to the wording. Dystrophin absence completely. This dystrophin, if it is absent, so absence of, right? The word is important. Absence of dystrophin. Okay, dystrophin, the peripheral protein, if it is absent in the cell membrane, that will cause a disease called as Duchenne's muscular dystrophy, DMD. Duchenne's muscular dystrophy. It will come again in your pathology, skeletal muscle pathology, as well as it will also come in your orthopedics medicine also. Okay, Duchenne's muscular dystrophy. Duchenne's muscular dystrophy is due to complete absence of this dystrophin. Okay, but if it is defective or deficiency, if they use these words, defective or deficiency of dystrophin, okay, defective or deficiency of dystrophin, that will cause some other disease that is called as Becker's muscular dystrophy. Okay, Becker's muscular dystrophy. This one is DMD means Duchenne's muscular dystrophy, that is complete absence. Becker's muscular dystrophy is due to deficiency of dystrophin. They will play tricks with you. Okay, remember this. Now imagine there is a boy. Okay, there is a boy with Duchenne's muscular dystrophy. Okay, there is a boy born with Duchenne's muscular dystrophy, DMD baby. Okay. Now, do you think his muscles are strong or weak? Definitely the muscles are going to be weak because this dystrophin is not there. Dystrophin is not there. Dystrophin will give the tensile strength to the muscles. It will give strength to the muscles, tensile strength to the cell membrane. But when the DMD, in the DMD, Duchenne's muscular dystrophy, the baby's muscles are going to be weak. So if you ask the baby to sit and stand, he can't do that. Okay, if you ask the baby to sit and stand, he can't do that like a normal person. He will take the help of the upper extremities. He will take the help of the hands to stand. Okay, look at this. See, here I'm showing you. Now the baby, this is the baby with the Duchenne's muscular dystrophy. You ask the baby to sit. See, if you ask the baby to stand, you see what he's doing. He's taking the support from his upper extremities to stand, to lift his body. Okay, so this is called as Gover sign, and that's the question which was asked. Okay, so these babies with the Duchenne's muscular dystrophy are going to have which sign? The sign is called as Gover sign. Okay, Gover sign is going to be positive. So these babies' muscle, the muscles are going to be completely getting atrophic. The muscles will be destroyed. So actually, the muscles are getting damaged. If you look at the calf of this baby's calf muscle in the leg, if you look at the calf of this muscle, one thing I want you to know, sir, the muscle is getting damaged continuously. The muscles are getting damaged because the muscles are not having proper strength. But if you are using those muscles, the muscle membrane will be damaged. When the muscle membranes are damaging, the cells will die. Okay, the cells will die. The muscle cells are dying. So in the place of muscle cells, actually the fat will be deposited. Okay, in their calf, actually in their calf muscles, more and more fat will be deposited. So if you look at their calves, okay, if you look at their calf muscle, They're actually bulkier. They're actually big. So this is called as pseudo calf hypertrophy. Okay, this is called as what? Pseudo calf hypertrophy seen in Duchenne's muscular dystrophy. Okay, pseudo calf hypertrophy. Why it is called as a pseudo hypertrophy? Because actually it's not a muscle that is increasing in size. It's not the muscle that is increasing in size. It's a fat that is getting deposited. Okay, it's a fat deposition. Okay, it's a fat deposition in the calf area. Now, these babies, in one of the exams they have asked, so the baby is having Duchenne's muscular dystrophy. What is the most common cause of death? What is the most common cause of death? See, their muscles are weak, so even their diaphragm is weak. Okay, there is a chance that their diaphragm fail to contract, that can lead to respiratory failure. Respiratory failure. Okay, because diaphragm is a skeletal muscle. Okay, it's not contracting properly because the dystrophin is not there. So the most common cause of death is respiratory failure that can kill the babies. Okay, these are some important points which I want you to know. Okay. So finally, just tell me, sir, spectrin. Sir, it's a protein, sir. Which kind of protein? It's a peripheral protein. Ankyrin peripheral protein. Dystrophin peripheral protein. All these three are peripheral proteins. Okay. Now, the last and final thing is the lipid anchored protein. What you need to know regarding the lipid anchored protein? What you should know? See, the example. Okay, the example of this lipid anchored protein is, okay, GPI. Okay, GPA. The name of this protein itself is called as a GPA. Okay, sir, where is this GPA present? It is also present in, okay, let me draw it here itself. You are having RBCs, right? Listen, it will come again in your pathology also. This is your RBC. Okay, in RBC cell membrane, okay, there is a lipid anchored protein. What is this lipid anchored protein called as? GPI. Okay. Now, this protein is very much important. Okay, this protein is very much important to prevent the destruction of RBCs. For example, say in your body, for example, whenever there is infection, okay, whenever there is infection in your body, complement proteins are activated. Complement proteins. You know, complement proteins, whenever they're activated, they forms what? Membrane attack complex. This membrane attack complex can attack bacteria. So this membrane attack complex can also attack our own cells. But our cells are not getting destroyed because we have what? This GPI. Okay, so this GPI actually, like, with the help of something called as a DAF, decay accelerating factor, and MIR, there is one more thing called as membrane induced reactive lysis. And right now you don't need to remember. So this, because of the presence of this GPI, what this GPI will do? It inhibits the membrane attack complex. So it prevents the destruction of RBCs. So actually this GPI is a good thing. And what is that GPI? So GPI is a lipid anchored protein. So if you have absence of this GPI, sir, this GPI protein is absent. So that will cause what? That will cause a disease where your RBCs will be destroyed. Okay, your RBCs will be destroyed. That is called as paroxysmal nocturnal hematuria. Okay, so paroxysmal nocturnal, that's PNH, paroxysmal nocturnal hematuria is due to absence of this lipid anchored protein called as GPI. Okay, when this GPI is absent, the activated complements, they can destroy your RBC. Okay, it's done. So regarding proteins, I have discussed important points. All these points, whatever I have discussed, all are regarding the proteins only. Okay, we haven't still started the lipids. All these are important things for proteins. So you have any doubt? Tell me. If you have any doubt, please let me know. Sir, am I having network issue? Is that so? Mahima is saying that, there is a network issue. Is that so? No, right? It's clear, right? It's clear, right? So, buddies, is that clear? Oh, from my side, it's clear. Okay. Chalo, shall we start? Let's start about the lipids. General physiology, sir. General physiology is a boring topic. Even I don't like to teach the general physiology. Okay, general physiology is like, not very much, they're not very much high yielding, not like, simple questions will come, you can answer. But anyway, we can't leave anything for the June attempt. Lipids. चलो लिपिड्स के बारे में डिस्कस करेंगे. Lipids. So regarding lipids, for your exam, what you should know, sir. I have already explained you. What kind of lipids are there? There are phospholipids. Okay, there are phospholipids. There are glycolipids. Okay, and cholesterol. Who is not there? Triglycerides are not there in the cell membrane. Remember, in the last FMG exam, not the recent exam, FMG exam, last exam. Okay, last but one. Question was asked on the phospholipids. Do you know what is that question? Let me tell you. Are phospholipids, sir, you are telling in our cell membranes, phospholipids are there and they are the maximum. Okay, which lipid is maximum? Phospholipid is maximum. Can you give us any example of a phospholipid which is present in our cell membrane? In our cell membrane, yes, I will give you. So what are these? Look, one is dipalmitoyl. Okay, dipalmitoyl phosphatidylcholine. Phosphatidylcholine. Dipalmitoyl phosphatidylcholine. So simply we regard it as a DPPC. Sir, where we have studied about this dipalmityl phosphatidylcholine, it is also a major lipid in the surfactant. It's also a major lipid in the surfactant, true, but it is also present in our cell membranes, true. It's also present in our cell membranes, sir, no doubt. Next one, sphingomyelin. Sphingomyelin. So they will ask you, sphingomyelin is a phospholipid, not a glycolipid. Phosphatidylcholine, it's a phospholipid, true. Next, phosphatidylserine. Question asked on phosphatidylserine, true. And that I said, the last FMG exam, what is the question asked? This is the question. Cardiolipin. Okay, cardiolipin. So tell me, cardiolipin is what? It's a lipid. It's which lipid? Which type of lipid? It's a phospholipid. Sir, cardiolipin, yes, it is present in our cell membranes, but this cardiolipin is mainly present in which cell membranes? Mitochondria. Mitochondrial membranes. Mitochondria. This is the question asked. Cardiolipin is mainly present in mitochondrial membranes. Mitochondria was given in the exam. Cardiolipin is a lipid. It's a phospholipid mainly present in the mitochondria. Now, I want to integrate one more thing. Okay, one more point I want to integrate. So, there is a disease in which anti-cardiolipin antibodies are seen. Okay, anti-cardiolipin. Okay, anti-cardiolipin antibodies seen in. Anyone, let me check. Anyone can say? There is a disease where the patient is going to have anti-cardiolipin antibodies. Okay, anti-cardiolipin antibodies. Anyone? Excellent, Shalu. Excellent. It's Apla syndrome. Okay. It's Apla syndrome, antiphospholipid, antibody syndrome, that thing, as well as one more disease, infection. Okay, one more infectious condition. Anti-cardiolipin antibodies are also positive in syphilis. Okay. One is Apla syndrome. Apla stands for anti-phospholipid antibody syndrome. Okay, antiphospholipid antibody syndrome. This is one condition. Second one is syphilis. Syphilis, don't forget, it's because of which organism? Syphilis. Treponema pallidum. Okay, Treponema pallidum. Treponema pallidum, syphilis. And also, remember SLE. Okay, even in SLE, you can have this anti-cardiolipin antibodies. Okay, done. Now, regarding this phosphatidylserine, what you need to know for your exam? Sir, phosphatidylserine, normal cells, look, okay, normal cells, they, let me put a normal healthy cell. See, this is a normal healthy cell. Okay, normal cell, healthy cell. Okay, see this phosphatidylserine. Right now, I'm talking about phosphatidylserine. See this phosphatidylserine. Yes, it's a phospholipid, but where it is present? It is present towards the cytoplasm. Means it's present inside. Okay, so let me write here. This is phosphatidylserine. PS means phosphatidylserine. Okay, it is internalized. Okay, it is internalized. But if a cell have committed, okay, suicide, or if a cell have decided to undergo apoptosis, now the cell is undergoing apoptosis. It have decided to undergo what? Apoptosis. The cell is dying. Okay, now this cell, it is going to do what? It is going to express the phosphatidylserine outward so that macrophages will come and eat this cell. Okay, so that macrophages will come and eat the apoptotic bodies, remaining apoptotic bodies. So what is happening? So the phosphatidylserine, okay, in which cell? Apoptotic cell. Okay, apoptotic cell. What is happening? Phosphatidylserine is getting externalized. Okay, externalized. Okay, so that's the one point which I want you to know. So we can identify this apoptotic cell. We can identify this apoptotic cell. How? Because we can use something called as annexin 5. Okay, annexin 5. This annexin 5 will go and bind with the annexin 5 in an apoptotic cell. It will go and bind with the phosphatidylserine because now phosphatidylserine is outside. So annexin 5, it will go and bind with this phosphatidylserine, and once it binds with the phosphatidylserine, it gives the lighting. It gives the lighting. So fluorescence will be seen. So that's why annexin 5, it's a dye. Actually, it's a dye. It is used as a marker of. It's used as what? Marker of apoptosis. Okay, it's a marker of apoptosis. So this is the point which I want you to know. So regarding phosphatidylserine. So phospholipids are there, glycolipids are there, and cholesterol is there. These are the points. Cholesterol is there. Don't forget, cholesterol is what? It's a fluidity buffer. Okay. Now, glycolipids. Regarding glycolipids, I want you to know only one point. Okay, glycolipid. So there are two different types of glycolipids. Let me write here itself. Okay, let me write here. Glycolipids. Okay, glycolipids. So there are two types of glycolipids. Actually, this is the biochemistry. There are cerebrosides. Okay, there are cerebrosides and gangliosides. Okay, cerebrosides and gangliosides. So now tell me, cerebroside and ganglioside, what are they? Are they proteins? No. Are they lipids? Yes. Are they phospholipids? No. They are glycolipids. Glycolipid means what? It's a lipid molecule to which some glucose molecule is attached. Okay, so they are called as a glycolipids. Okay, now cerebrosides and gangliosides. One question which you need to know from your microbiology as well as from the physiology is there is a special type of glycolipid called as, okay, GM2. Okay, this is a special type of ganglioside, I should say, GM2 ganglioside. Okay, GM2 ganglioside on the membranes. It's there on our membranes. GM2 ganglioside is there in our membranes. So what is the importance of this GM2? GM2 ganglioside is it acts as, okay, receptor for chlorotoxin. It acts as receptor for entry of chlorotoxin into cells. Okay, let me teach you what exactly I want you to know is, look, imagine this is your intestine. So this is your intestine. Okay. Now here are what? These are the intestinal enterocytes. These are the lining cells. These are the lining cells. Now cell have what? Cell membrane. This is the cell membrane, you know it. This is the cell membrane, sir. Okay. Now on the cell membrane there is a lipid called as a GM2 ganglioside. Okay, let me look. GM2 ganglioside, let me show you. Here there is a lipid called as, look, this is GM2 ganglioside. But what is GM2 ganglioside? It acts like a receptor, GM2. Okay, so with the help of this GM2 ganglioside, once you have Vibrio cholera, okay, so this cholera, it have entered into your body, okay, via the contaminated water, via the contaminated food and water, the cholera entered into your body. This cholera, what it will produce? It will produce this toxin. Okay, cholera, what it is producing? It is producing this toxin called as cholera toxin. Now this cholera toxin, now it enters into the cell through the GM2 ganglioside. Now, where is the cholera toxin? For example, here, this is the cholera toxin. Now this cholera toxin, do you know what it will do? It will increases the CAMP levels inside the cell. It increases this is also the question. Cholera toxin increases the CAMP levels, microbiology. Now, when the CAMP levels increases inside the cell, now these enterocytes, do you know what they will do? They will secrete more sodium. They will secrete more sodium into the intestines. More and more sodium is getting secreted. Wherever there is sodium, water follows the sodium. So, because more sodium is going out in the feces, okay, more sodium is going into the feces, so more water will follow into the feces. That will cause what? That's why cholera patients are going to have diarrhea. Okay, the patients are going to have what? Diarrhea. Okay, because cholera, what it is going to do? The Vibrio cholera, they produces a toxin. The toxin will enter into the cells, increase the CAMP levels. That increase in the CAMP levels ultimately increases the secretion of sodium into the intestines. That sodium, you know, wherever there is sodium, water, the sodium absorbs the water, and because of this water, the patient is going to have diarrhea. And this diarrhea, how the diarrhea is going to look like? The diarrhea is going to look like rice water. Rice water. So this is rice watery diarrhea. The diarrhea, you just take rice and wash the rice. Okay, just wash the rice. The water is going to look white color, right? So that the patient is also going to have diarrhea in such way. So rice watery diarrhea. Okay, so why I have explained all these things? Because the GM2 ganglioside, it's a glycolipid. It's a glycolipid. So can you tell me one condition where the patient is going to have pea soup diarrhea? This is a totally different integrated thing. Pea soup. Pea soup diarrhea. Okay, pea soup diarrhea. This seen in which infection? Typhoid or enteric fever? Enteric fever. So both are same, sir. Don't think typhoid or enteric fever. Both are same. Typhoid is also called as enteric fever. Both are same. Okay. So if a patient is having typhoid, then also the patient is going to have diarrhea. That diarrhea looks like a pea soup. I don't know who like, you know, have kept all this. Okay. But anyway. So with this, important points about the cell membrane are completed. Okay. Now, after this, let's discuss a new topic, that is cytoskeleton. Okay, cytoskeleton. So shall I continue with the cytoskeleton? Shall I continue with the cytoskeleton? Today, my health is also little, like, you know, not good. Got cold. So cytoskeleton, let's take it. Cytoskeleton. Now, we are having skeleton, right? We are all having skeleton. Okay, we do all have skeleton. What is the purpose of skeleton in our body? It gives the framework. It gives the structure and shape to our body. Okay, even cells do have the skeleton. Okay, for example, imagine this is a cell. In the cell, there is a network. There is a framework. Okay, so there are these proteinaceous molecules which are giving a framework. Okay, these are like a pillars, so that the cell is having a shape. So what is this network called as? That is called as a cytoskeleton. Okay, that's called a cytoskeleton. So now tell me, what is the function of cytoskeleton? Cytoskeleton function is is to give the shape to the cell. Gives shape to cells. Okay. So now what are these, like, cytoskeletal filaments? There are certain filaments in the cell which gives that shape. So what are these filaments? So let me write the cytoskeletal filaments are microtubules. There are three things: microtubules, microfilaments, and intermediate filaments. Okay, intermediate filaments. Okay, so microtubules, microfilaments, and intermediate filaments. Now, questions which they will ask in your exam is, okay, sir, who are more in number? Who are more in number? So this microtubules, microfilaments, and intermediate filaments. See, based on their size, we have classified. Okay, we have classified based on their size. Microtubules, okay, are big. Intermediate filaments are average. Microfilaments are small in size. Okay, based on that. Microtubules, for example, if you ask me, if you want to know the diameter of this tubules, for example, the diameter of this tubule, okay, it's a protein actually. The diameter of this tubules is going to be 25 nanometers. 25 nanometers based on size. Intermediate filaments will be 10 nanometers. Microfilaments will be 7 nanometers. Okay, based on size, we have divided. So, who are more in number, more abundant? Intermediate filaments are more abundant, right? Okay, they are more abundant in number. But who are more strongest? The more strongest cytoskeletal filaments are microtubules are more strongest, right? Next, one more question is, sir, when the cell is growing, see, when we are growing, our skeleton also grows. Okay, when we are growing, our skeleton also grows. In the same way, our cytoskeleton also grows, sir. But one filament will not grow. Okay, one filament will not grow. So who will grow and who will not grow? Is, say, microtubules, they are dynamic. Means they will grow, they will grow. Microfilaments are also dynamic. But this is the question asked. The intermediate filaments, they are static, which means they do not grow. Okay. Next, sir, examples of microtubules, like, not examples, I should say, sir, microtubules, hai na? Microtubules, sir. Sir, it is made up of what actually? Okay, microtubules. Yes, of course. For example, say, imagine this is a cell. Okay, imagine this is a cell. So there is a microtubule. So, for example, let me show you something like this. So imagine this is a microtubule from this side to this side. Microtubules. These are like pillars. Okay, microtubules. So these microtubules, they should be made. They are made up of what, sir? They are actually made up of proteins. Which proteins? Let me write here. Okay. So microtubules are made up of dynein. Sorry, they are made up of tubulins. Okay, microtubules are made up of proteins called as tubulins. There are alpha tubulins, beta tubulins. Okay, I will show you. Just wait. I will try to show you the image. See, for example, what is this? This is a microtubule. Look, this is a microtubule. Okay. Now, microtubules are made up of what? Sir, they are made up of these monomers, proteins. Okay, they are made up of this protein unit. See, they are called as what? Tubulins. Okay, alpha tubulin, beta tubulin, something like that. Okay, if you act just, they are acting like pillars. Okay, they will give the cell a structure. Okay, now the point which I want you to know is, please appreciate here. See, this microtubule have one positive end, one negative end. So what is that positive end? I have told you, microtubules, they will grow along with the cell, they will grow. So this side, new tubulin molecules are added so that they will grow. Okay, new tubulin molecules will be added, they will grow, sir. So positive end means what? The end where growth occurs, the end where growth occurs. Okay, so let me take this, keep it over there. Yeah, so Let's see. This is the question, sir. This is the question which was asked 20 days back. This is the question which was asked. Okay, I will explain you what is that question. But look, so there is a positive terminal, positive end, and negative end. Positive end means growth occurs. Growth occurs. Negative end, there is no growth. Now, second important point which I want you to know is, see, on this microtubules, there are these cars moving. Okay, there are these cars moving. What I want you to know is, sir, of course they give the, they are acting like pillars. They are giving the, like, shape and structure to the cell. Okay, but on this microtubules, there are certain molecules called as dynein, okay, and kinesin. Actually, they have legs and they actually move. They actually walk. Okay, they actually walk. So look at me. Look at me, sir. See, imagine this is a microtubule. Okay, in the cell there is a microtubule. Now, on this microtubule, look, on this microtubule, there is a molecule called as kinesin. It walks like this. Why it is walking? It actually carries the substances. It actually carries the substances, like for example, like a protein, okay, or some chemicals. So this kinesin, it walks on the microtubule. So microtubules, they are also helping in the transport of substances. Microtubules, they are a part of cytoskeleton. So cytoskeleton also helps in the transport of substances within the cell. So write that one point. So write this. साइटोस्केलेटन का एक और फंक्शन है, इट हेल्प्स इन इंट्रासेलुलर ट्रांसपोर्ट. Okay, intracellular transport, helps in the intracellular transport. Okay, so look, now what is this kinesin doing? Kinesin is moving towards the positive end. Dynein is moving towards the dynein. Where it is moving? It is moving towards the negative end. Okay, so within the cell, these molecules called as dynein and kinesin, they actually, by using the energy, by using the ATP, they actually walk on the microtubules and helps in the transport of substances. Okay, so let me write here dynein. This is the question which was asked. Dynein, recent exam, dynein. Okay, dynein, it helps in retrograde transport. Means retrograde means moves towards the positive end. That is called as a retrograde transport. Retrograde transport. Okay, retrograde transport means moving from the positive end towards negative end. That is called as a retrograde cargo or retrograde transport. Kinesin, it moves towards the positive end. That is called as anterograde. Anterograde transport. Okay, that is moving towards the positive end. Moving towards the positive end. Sir, how to remember this? How to remember this? How means we are all doctors, right? So DR. Okay, remember DR. Doctor. So dynein helps in retrograde transport. Dynein helps in retrograde transport. And what is the recent question, sir? 20 days back, what question was asked? Do you know what the question was asked? See, which of the dynein is a? Dynein is a. It's a motor protein. It is a walking. It's moving, right? It's a motor protein. Okay, it's a motor protein. Even in the rapid revision session also, I, like, for your seniors, I was telling the same thing. This question will come. This question will come. Okay, same question came. Dynein, kinesin. These are motor proteins in your cells. If you want to know, there is one more motor protein that is called as myosin. Myosin, the muscles, that is also a motor protein. So three things you should remember: dynein, kinesin, and myosin. These are the motor proteins. Okay, so done. This is also completed. Retrograde cargo is also completed. Now after this, what else you should know? Let me show you one diagram. You just tell me what it is. Sir, this is a cell. Okay, this is a cell. Now these are the centrioles. So we say these are the centrioles. Now can you tell me what exactly is happening now here? Can you tell me what exactly is happening? This is cell division, right? Cells are dividing. Okay, the cells are dividing. The chromosomes came to the equatorial plate. Now cell division occurs, So what are these green color filaments? What are these green color thing? That's also your microtubules. Okay, microtubules. So now tell me, microtubules are a part of, sir, microtubules are a part of cytoskeleton. So one more function of the cytoskeleton, right? One more function of the cytoskeleton is cell division. Okay, one more function of the cytoskeleton is what? Cell division. So microtubules helps in cell division, true. Okay, so now one integrated question. Microtubule inhibitors. Microtubule inhibitors. So if you inhibit the microtubules, cells can't divide, So microtubule inhibitors can be used where? They can be used as anti-cancer drugs. Okay, microtubule inhibitors can be used as anti-cancer drugs. They will ask you the example. What are the examples? Microtubule inhibitors. Can you give me any example of a microtubule inhibitor? Microtubule inhibitors inhibit the microtubule formation. Without microtubule formation, cell division will not occur. Without cell division, cancer cannot grow. So examples are, okay, any examples? Okay, let me see. Any one of you can answer it or not. Sorry. Yeah. Can anyone answer? Microtubule inhibitors? Nucleides. Vincristin, vinblastin, or one more drug, famous drug for your exam, colchicine. Okay, colchicine, which is also used for the acute gout. Okay, colchicine, acute gout. Famous question, acute gout also you can use it. Okay. So these are the important points about the microtubules. Okay. Now, after this, what else you should know? I have to teach you example of microfilament now. Okay, I have to teach you the example of microfilaments. So microfilaments include actin. Actin. Myosin. These are microfilaments. Guys, right now I'm talking about the cytoskeletal actin and cytoskeletal myosin. Array, in your cells, look, in your cells, not only in the skeletal muscles, not only in the muscles, each and every cell, there is actin. That actin will give the shape to the cell. This is the cytoskeletal actin. This is not doing contraction. That is there in the muscle. Same actin. But here actin is giving the shape to the cell, true structure to the cell. This is cytoskeletal actin. Remember, one of the example of microfilament is actin, myosin, true. And the last thing which I want you to know is intermediate filaments. Take the heading intermediate filaments. Intermediate filaments. So regarding intermediate filaments, what you should know. Regarding intermediate filaments, what you should know is, sir, they are specific to the cell. Specific. Okay, they are specific to the cell, which means, for example, if I say one intermediate filament like keratin, it is only present in particular cells. It's not present in all our cells. No, it is not present in all our cells. Keratin is only present in epithelial cells. Okay, something like that. They are specific to cells. Actin is present in all cells. Okay, actin is present in all cells. Microtubules are present in all cells. But intermediate filaments, they are specific to the particular cells. For example, one intermediate filament, keratin. Where it is present? It is present in epithelial cells. Okay, it's only present in the epithelial cells. Because it is present only in the epithelial cells, keratin is considered as marker of, it's a tumor marker of squamous cell carcinoma. It's a tumor marker of squamous cell carcinoma because squamous cell carcinomas are the cancers of epithelial cells. Okay, see, if epithelial cells, they get cancer, They are called as squamous cell carcinomas. So in squamous cell carcinomas, which intermediate filaments are seen? Keratin. Aha, okay. If you see keratin, you got a cancer biopsy, you got a biopsy. Okay, you got a biopsy. And you are seeing inside the cells, you are keratin. Now you know. Sir, this is a cancer of epithelial cells. This is a cancer of epithelial lining. Okay, keratin is the tumor marker of squamous cell carcinomas. Okay, and in general pathology also, this thing is very important. What is that? So squamous cell carcinomas, inside the squamous cell carcinomas, for example, see, this is one cell, one cancer cell. Inside that one cancer cell, what you will see? Keratin pearls. Keratin pearls are seen. Okay, keratin pearls, neoplasia, squamous cell carcinomas, keratin pearls. Have you studied about that? Have you studied about that? Keratin pearls are seen in squamous cell carcinomas. Come on, guys. Just let me know. Have you studied or not? Anand is saying yes. What about the others? Others not studying? Haven't studied? Okay. Okay. Anyway, let's continue. Next, the next intermediate filament which I want you to know is the desmin. Right, desmin. Sir, this desmin, yes, it's an intermediate filament. It is present where? It's present only in skeletal muscles. Okay, it's present in skeletal muscles. So it's a tumor marker of what? It's a tumor marker of. It's a tumor marker of cancer of skeletal muscles is called as rhabdomyosarcoma. Okay. So in rhabdomyosarcoma, what is the tumor marker that is used to know whether it's rhabdomyosarcoma or not? Check for desmin. If desmin is there, yes, it is rhabdomyosarcoma, something like that. Okay. So the next intermediate filament which I want you to know is GFAP. Okay. GFAP. Sir, what is this GFAP? Glial fibrillary acidic protein. Okay. Sir, glial fibrillary acidic protein. Okay, glial fibrillary acidic protein. So this glial fibrillary acidic protein is present in astrocytes. Okay, it's present where? In astrocytes, in your brain, there are astrocytes. So in this cells, only in the cells, astrocytes, there is an intermediate filament called as the glial fibrillary acidic protein. So now you tell me it's a tumor marker of what? It's a tumor marker of. Okay, it's a tumor marker of astrocytoma. Okay, astrocytoma, tumor of astrocytes, astrocytoma. Okay, so the tumor of astrocytes. Okay, if the astrocytes are getting cancer, that is also called as glioblastoma multiforme. Okay, glioblastoma multiforme. So in glioblastoma multiforme or pilocytic astrocytoma, what you will see, sir, in these cancers, glioblastoma multiforme, grade 4, means like no, serious cancer, glioblastoma multiforme, pilocytic astrocytoma, these are the cancers of astrocytes. Okay, these are the cancers of astrocytes. Inside these cancers, what you will see? Inside these cancers, you will see Rosenthal fibers. Now, what are these Rosenthal fibers, sir? These Rosenthal fibers are nothing but glial fibrillary acidic protein. Okay, sir. And there are two astrocytomas which are called as glioblastoma multiforme, pilocytic astrocytoma. In this cancerous cells, what you will see, Rosenthal fibers are seen. FMG, very favorite question from your patho. These Rosenthal fibers are what? Rosenthal fibers are made up of glial fibrillary acidic protein. That's a question. Okay. Next, vimentin. The next thing is vimentin. Vimentin. So this vimentin, where it is present? It's present in your mesenchymal cells are like, connective tissue cells like fibroblasts, are connective tissue cells. Okay, connective tissue cells. Connective tissue cells. Okay. So that's the one point which I want you to know. If there is a cancer which is coming from the connective tissue cells, like if there is any cancer from the connective tissue cells, there you will see Vimentin. So James, this is not asked. Only once this question was asked, a long back, that too long back. Vimentin, it is mainly present in connective tissue cells or fibroblasts. What is Vimentin? Vimentin is a intermediate filament. Vimentin is an intermediate filament. Okay, that's it. So this topic is also completed. Cytoskeleton, whatever you need to know, you're done. So shall we continue with the next topic? The next topic which I want you to write is cellular transport. Simple topic, cellular transport. Okay. Chalo, take the notes. Cellular transport. In the topic of cellular transport, first thing which I want you to know is, so transport is of how many types? So there is active transport, right? There is active transport and passive transport. Okay, for your exam, you should know there are active transport and passive transport. 1000%. One question will be there on the transport, like either gluts, either SGLTs, or either pumps. They will ask you one question, no doubt in that. Okay, listen this topic carefully. Sir, active transport. It is of further how many types? Sir, active transport is of again two types. Primary active transport. Okay, primary active transport. Let me write full form. Primary active transport and secondary active transport. Primary active and secondary active. So passive transport is of further how many types? Let me write here. So passive transport mein there is diffusion. Okay, mainly just wait. By three types. Two types is enough for your FMG. So diffusion is there as well as osmosis. Okay, diffusion as well as osmosis. Now in diffusion, there is simple diffusion as well as facilitated diffusion. Okay, simple diffusion as well as facilitated diffusion. Okay, now we have to discuss one by one. First, what is primary active transport, sir? Primary active transport, let's take the heading. Okay, so you know, first of all, active transport means right here, energy is required. Energy required. Okay, required, energy required. Here, not required, energy not required. Okay, energy not required. So diffusion doesn't require energy, osmosis doesn't require energy, simple diffusion, facilitated diffusion, they do not require energy. Okay, so let's write primary active transport. So this primary active transport, what is happening? There is a direct, the word is important, direct use of energy. In the transport of substances, energy is directly used in the form of ATP. Okay, there is a direct use of energy in the form of ATP. Okay, then what are the examples of primary active transport, sir? Remember this, at least till your exam. The moment you see the word ATPase, wherever you see the word ATPase, are pumps. They are all examples of primary active transport. See, for example, sodium, potassium, ATPase. Okay, see, the word ATPase is there. So here, sodium is moving, potassium is moving. and ATP is getting utilized. So there is transport of substances, sir. Sodium, 3 sodium goes out of the cell, 2 potassium comes into the cell with the help of sodium, potassium, ATPase. So this is an example of the transport is an example of primary active transport. I believe you already know this. So there is a transporter, there is a protein which will throw 3 sodium out of the cell, brings 2 potassium into the cell. So the transport is happening, cellular transport is happening. But with the help of ATP, energy is being utilized. So that's an example of primary active transport. Okay. Second thing, sodium, potassium, ATPases. Next, for example, if you see proton pump in the stomach, proton pump which secretes what? Acid. That's also an example of primary active transport. Next, in your skeletal muscles, there will be calcium ATPase. That's also example of primary active transport. So wherever you see the word ATPase, that's all example of primary active transport, where there is a direct use of energy. Okay, where there is direct use of energy. Okay. So regarding sodium potassium ATPase, I want you to know certain important points. What are they? See, the sodium potassium ATPase. Okay. See, there are certain drugs, or you can say there are certain hormones which will activate the activity of, okay, which will increase the activity of sodium potassium ATPases. So who increases the activity of sodium potassium ATPases? That's one of the question. So who increases the activity of sodium potassium ATPases? See, that is thyroid hormone. Already I have discussed. Thyroid hormones increases the basal metabolic rate. Thyroid hormone increases the number of sodium potassium ATPases. You know it. So thyroid hormones. So let me write here. Thyroid hormones. They increases the activity of sodium potassium ATPase. That's why the plus symbol. Then who inhibit the sodium potassium ATPase? Highly integrated with the pharmacology. Who inhibits sodium potassium ATPases? There is a drug called as digoxin or digitoxin. What are they? They are digitalis group of drugs. So digitalis group of drugs like digoxin, digitalis group of drugs. And one more drug called as obein. Okay, obein. They blocks the sodium potassium ATPases. Both these two increases the cardiac contractility. They are cardiac inotropes. They increases the cardiac contractility by blocking sodium potassium ATPases. Okay. Okay. And dopamine. Okay. So DOD, I used to remember like DOD. Okay. DOD dot. DOD dot. Okay. So digitalis, obein, these are the drugs. These two are drugs. Digitalis and obein, these are the drugs. Okay. They will inhibit the activity of sodium potassium ATPases. Okay. Know that one point. Next, what else you should know is, sir, this sodium potassium ATPase, hai na? Okay, it's there. Of course, it's a protein, sir. It's a protein, no doubt in that. Is it a carrier protein or is it a channel? Is it a carrier protein? This is also what I want you to know. Is it a carrier protein or is it a channel? Okay. So let's write here. Now students will be thinking, most of the students will think, sir, sodium potassium ATPases. So most of the students, they will think that it's a channel. No, it's a carrier protein. Carrier protein. It's a carrier protein. So now students will have it out. Sir, what is it meant by carrier protein? See, look here. Channel means it's just like a small hole in the membrane. Okay, see, for example, if this is a cell, what are channels? Look, channels means, okay, so these are proteins. Channels means they are proteins, simply proteins, which will allow the substances in and out. That's it. There is no change in structure. This is a channel. Okay, they do not have any shape change. They do not undergo any shape change. But what is a carrier? Okay, carrier protein means, for example, see here, this is a carrier. So carrier protein means while transporting the substances, do you know what happens while transporting the substances? They will undergo their transformational change. The shape will undergo change. For example, look at me. Say, if imagine this is the sodium potassium ATPase. Look at me. Look at me. This is a sodium potassium ATPase. There is alpha subunit. There is beta subunit. Alpha subunit, beta subunit. Now, while transporting the sodium and potassium out, these subunits, they will rotate. They will rotate and transport the substances. So they will undergo shape change. If any protein undergoes a conformational change or shape change while transporting the substances, they are called as carrier proteins. Our sodium potassium ATPase is not a channel. It's not a channel. It is a carrier protein. Okay. So let me write here. It's a carrier protein because it undergoes what? Shape change. Okay. So with this, important points about the sodium potassium ATPase are completed. If you know this much, it's enough. Like, too much details, like, alpha subunit, beta subunit, so much things are not needed. Just leave it. Now, secondary active transport. Primary ho gaya. Secondary active transport. In secondary active transport, there is indirect use of energy. Okay, there is indirect use of energy. Okay. For the examples, sir, already I have given you. Wherever you see the word symporters, okay, symporters are co-transporters. Okay, symporter co-transporters are antiporters are exchangers. Okay, so they're all examples of secondary active transport. Okay, for example, let me give you one example. Favorite question for the examiner, repeatedly tested, that is SGLT. Okay, SGLT, that is sodium glucose transporter. Sodium glucose transporter. So see, sodium is moving. That movement of sodium will give the energy for the movement of glucose. Remember it like that. Simple. The movement of sodium is giving the energy for the movement of glucose. So the energy is indirectly utilized. Okay, the energy is indirectly utilized. So that's why, see, glucose is transported because sodium is moving. The movement of sodium from high concentration to low concentration will give the energy, will release the energy. By using that energy, glucose will be transported. So sodium glucose co-transport, SGLT type 1, SGLT type 2. Where are they present? SGLT type 1, it is present in your intestines. Question asked. For the absorption of glucose. For the absorption of glucose in your intestines, what do you require? SGLT1. For the absorption of, for the reabsorption of, I should say, for the reabsorption of glucose in the nephrons, what do you require? SGLT2. You know, it's there where? In the PCT of the nephrons. Like, it's present in the PCT of the nephrons for reabsorption of glucose. Okay, let me write intestines, glucose absorption. So glucose absorb करने के लिए in your intestines, what do you require? SGLT. In nephrons for glucose reabsorption. Okay, done, sir. Secondary active transport also completed. Indirect use of energy. Okay, all pumps are primary active transport. All pumps are primary active transport. Secondary active transport, symporters, antiporters. Next, let's discuss about diffusion. First diffusion is simple diffusion. Let me write in a pink color. Simple diffusion. So who will undergo simple diffusion? Gases. Direct question. Gases. Like oxygen transport from high partial pressure to low partial pressure. Oxygen transport. Carbon dioxide transport. So oxygen transport, carbon dioxide transport, they are examples of simple diffusion from high partial pressure to low partial pressure. Okay, from high partial pressure to low partial pressure, oxygen is moving. So it doesn't require any energy. Simply it will happen. Just by nature it happens. From high partial pressure to low partial pressure, gases will move. There is no requirement of any energy, no requirement of any special proteins. Nothing is required. So that is simple diffusion. Then what is facilitated diffusion? Facilitated diffusion. Okay, facilitated diffusion. What is facilitated diffusion, sir? Sir, here the diffusion is facilitated, means someone is helping. See, Example, let me tell you. Okay, let me, before telling you the example, who is helping facilitated diffusion? See, it is also no energy required. No energy required. Here also no energy required. No need of energy. No need of energy. But who is required in facilitated diffusion? Proteins. Okay, proteins are required. Proteins are involved. So, for example, let me tell you. See, this is your blood. Okay, this is your blood vessel cell. Okay, here is your adipose tissue. Let me take your adipose tissue in a little different color. Let me take it in little difference. Okay, so here is your adipose tissue. Let's say this is your adipose tissue. Now, in your adipose tissue, there is less glucose present. See, here the glucose is less. Okay, here there is more glucose. More glucose. So, glucose can have a gradient. Yes, glucose is having a gradient. It can move from high concentration to low concentration. Glucose can go from high concentration to low concentration, but glucose is a big molecule. It cannot go. Glucose is a big molecule. It cannot go. It cannot enter. Okay, it cannot enter. Okay, it cannot enter. So, for that purpose, there is a special channel which is present over here. What is the channel? They are gluts. What is this? GLUT4, G-L-U-T, glucose transporter type 4. Okay, glucose transporter type 4. So through this glucose transporter type 4, now glucose is entering into the cell. Means from high concentration to low concentration. No need of energy, any energy. But this diffusion means substance is moving from high concentration to low concentration. So that is diffusion. Substance is moving from high concentration to low concentration. But here a protein is helping in this process. So that's why it is called as a facilitated diffusion. Remember, all gluts. Okay, all gluts are examples of facilitated diffusion. You know, one of the recent exam, the question was asked, GLUT2 is mainly present in, options I will give you, look, GLUT2, it's mainly present in A, B, C. One liver, next one is kidney, nephrons, pancreas, beta cells, pancreatic beta cells, intestines. Okay, at least tell me ABC intestines. Okay, so GLUT2 is mainly present in. Anyone, can you tell me where GLUT2, you know, glucose transporters means they are all examples of facilitated diffusion. Glucose moves, facilitated diffusion. Okay. So glucose transporter type 2 is mainly present where? See, it's present everywhere, but in one exam, in that exam, this is the exact question which was asked. Glucose transporter is type 2. This is glucose transporter type 2. It is present everywhere. But if you have to pick one answer, pick liver. Okay. It's present everywhere. Mainly, it is present in the liver. Okay, glucose transporter type 2 is mainly present in the liver. In the liver, gluconeogenesis will occur. Okay, gluconeogenesis will occur. So for the purpose of gluconeogenesis, to send the glucose back into the blood, you require GLUT2. Okay, so GLUT2, where it is present? It is present in those tissues which are capable of gluconeogenesis. So that's the biochemistry. So wherever gluconeogenesis occurs, there you will find GLUT2. Okay. Okay. So you are asking, like, you know, it's a sodium potassium pump. Sodium potassium ATPase. For just talking, like, you know, when we are like, you know, usually when we talk, we simply say sodium potassium channel. But it is actually sodium potassium pump. It's a carrier protein. That's why I have explained you. Most of the students simply they will think, sodium potassium channel, it's a channel protein. No, it's not a channel protein. See, simply when we are talking, we say sodium potassium channel, it transports sodium out, potassium in. But if I'm talking about proteins, it is a carrier protein, not a channel protein. Okay. So done. This is also completed. Facilitated diffusion, simple diffusion are done. Now after this, let's discuss about osmosis. Okay, osmosis. Okay, now let's discuss about the osmosis. Now let me give you two beakers. Okay, I'm giving you two beakers. Beaker A, beaker B. It's filled with the water. Sorry. See, both are filled with the water. Okay. Now, I'm telling you the osmolarity here. Osmolarity of this solution, of this fluid is 100 milliosmoles. Here, the osmolarity of this solution, maybe it is 10 milliosmoles. Okay, 10 milliosmoles. Now, I have connected this beaker. Okay, I have connected this beaker. Look. With a tube. With a tube, I have connected this beaker. Now tell me, from where to where the water will move? Okay, from where to where the water will move? Osmosis. From where to where the water will move? Will the water move from A to B or B to A? From beaker number A to B or beaker number B to A? Let me check. Satish is saying A to B. Rahul is saying A to B. B to A or A to B? So this is osmosis. Okay. Let me tell you. See here, high osmolarity is there. High osmolarity means what? High osmolarity means more sodium is there. Wherever there is sodium, water moves towards the sodium. So 90% of the students, they will simply confuse as here is high, here is low. So high to low, they will say something like that. Sir, this is osmosis. Osmosis, water will move, the fluids. Okay, fluid will move from water, moves from water moves from low osmolarity to high osmolarity. Okay, so that is B to A. The water will move from B to A. So don't confuse. Okay, so here more free water is there. More free water is there. Here more sodium is there. Okay, so the sodium is dragging the water. Wherever there is sodium, water moves towards the sodium because it's having osmotic potential. Understood? Osmosis also completed. Now after osmosis, let me tell you a special type of transport. That is endocytosis and exocytosis. Some questions. Now, endocytosis, is it active or passive transport? It is active transport only. Endocytosis, you require the ATP. Okay. But why endocytosis is special? Because the transport of substances are happening in the form of vesicles. So, large substances. Okay, large substances are transported in vesicles. Okay, so endocytosis is the type of vesicular transport. Exocytosis, it's a type of vesicular transport. Exocytosis, see, vesicles are forming. Okay, so one question which I want you to know is for your exam, even like first year student knows this. Endocytosis, it includes phagocytosis, means see, cells are eating. Okay, microorganism, maybe a microorganism is taken into the cell in the form of a vesicle. By forming a vesicle, you are taking something from outside. Okay, something from outside. So that's why endo. Okay, endocytosis means cells are taking a substance, a big substance into the cell, eating. Now this phagocytosis is also called as cell eating. Cell eating means maybe the cell is eating a bacteria, a neutrophil is eating a bacteria or macrophage. After eating, what the cell will do? It will drink. Okay, that is called as a penocytosis. This is cell drinking. Cell drinking. Okay, when the cell is getting dehydrated, it will take the water molecules. Okay, it will take the water molecules by forming a vesicle. By forming a vesicle, even the cell is taking the water. So again, vesicle is coming into the cell. So why? That's why endocytosis. Okay, so that is cell drinking. Now, sir, what kind of questions that can come in your exam regarding endocytosis? Sir, endocytosis can be phagocytosis, pinocytosis, receptor mediated endocytosis, caveolae mediated endocytosis. So many things are there. For your exam, no need to remember. They will ask you in the formation of a vesicle. When you are forming a vesicle, look, when you are forming a vesicle, which proteins are helping? Here it was given. See, there are proteins called as clatharins, and caveolins. Clatharins and caveolins, they are involved in the formation of a vesicle. Okay, right. So which proteins are involved in endocytosis? Clatharins and caveolins. Question asked, clatharins and caveolins are involved in endocytosis. Endocytosis means vesicles, the substances are moving in the form of vesicles into the cell. The substances are moving into the cell by forming the vesicles. Okay. Clatharins, caveolins, endocytosis. Next, the last thing is exocytosis. Okay. Exocytosis. Sir, what is exocytosis? Look here carefully. Now, cell is producing some protein. Maybe, for example, in the endoplasmic reticulum and the Golgi complex, proteins are produced. Proteins are modified. Post-translational modification happened. Everything completed. Now, for example, proteins are synthesized. Now, these proteins have to go out of the cell. Okay, our hormone is synthesized. The hormone have to go out of the cell. So now this hormone is packaged. Okay, now the hormone is packaged, and this hormone is sending out in the vesicle. So this vesicle, see, this vesicle is forming, and that vesicle, it is coming and it is going out. It is releasing the contents outside. So this is called as exocytosis. Okay, so substances are moving out of the cell. Substances are moving out of the cell. So for that, what they will ask you. So exocytosis process ke liye, which proteins are required? So which proteins are required for the process of exocytosis? Okay, so I used to remember exocytosis. So I used to remember when I was a student, X means what? Exocytosis, X. Your X is like a snake, right? Your X is like a snake. Okay, so snare, something similar to snake. Okay, snare proteins. So snare proteins are helping in the process of exocytosis, means the substances are moving out. So remember, so endocytosis ke liye pathrins and caveolins are required. Exocytosis ke liye snare proteins, synaptobrevins. Okay, synaptobrevins, snare proteins are required. Okay. Done. With this, the topic of cellular transport is also completed. And remember, exocytosis, which ions are required for the process of exocytosis? You require calcium. Calcium is required for exocytosis. Okay, done, sir. 3 topics we have completed the general physiology. What are those 3 topics? Cell membrane, cytoskeleton, as well as cellular transport. If you have gone these 3 topics from the morning, definitely, sir, I can assure you, no doubt, if your luck is super good, 2 questions will be completed, sir, already done. Okay, 1 question 100% pakka. There is no doubt. 1 question from the transport, and you can expect 1 question from the cell membrane and cytoskeleton. 2 questions completed. Okay. Recently asked question was what? Dynein. Dynein is a molecular motor. It walks. It helps in retrograde transport. Okay. So shall we start the next topic? The next topic, which I want you to know, is cellular fluids. Okay, take the heading, cellular fluids or body fluids. Okay. Cellular fluids are the body fluids. Now my question to you, sir, how much fluid is there in our body? Okay, how much fluid is there in our body? Sir, 60% of our total body weight. For example, if you are 100 kilos, imagine you are 100 kilos. Sir, 60%, that is almost 60 kilos is water. Okay, 60% of total body weight, okay, is water. 60%. So 60% means, for example, in an adult, okay, adult who is weighing 70 kilos, if he is weighing 70 kilos, out of that 70 kilos, how much is water? That is 42 liters. 42 liters. So in an adult healthy individual, adult human, 42 liters of water is there in his body. Okay, right now in your body, how much water is there? 42 liters of water is there. So let me write, in males, they have 60% of total body weight as water. Now my question to you, females. The females have more percentage water or less percentage water? Females have more water or less water? Females have less water in their bodies. Okay, how much percent? 50%. But what is that? The 10%? Males have more water, females have less water. What is extra in the females? That extra 10%. 10% difference is there? No, that's fats. Female have more fats. Okay, females, they have more fats, like in the breast, in the abdomen, okay, in the thighs and buttock area, there is more fat. Okay. Now when I'm talking of children, sir, children's, they have even more water. That is 75% of children's, they have water. 75% of the total body weight is water. Done, sir. Now let's see the classification of the total body fluids. Now take the heading, total body water. Total body water. Now this total body water, it is divided mainly into, that is 42 liters, right? 42 liters. Okay, 42 liters. Now, just wait guys, 1 minute. Yeah. So total body water, it is mainly divided into two compartments. So what are these two compartments? Once look here. Sir, imagine these are your cells. Okay, these are your cells. So these are your tissues, these are your cells. So where is water present, sir? Can you tell me? Where is water? Sir, here is the blood vessel. Here are the blood vessels. So where is this water present, or where are the fluids present? Sir, inside our cells, water is there. There is a cytoplasm. Cytoplasm mein water hai. And in between our cells also, water is there. In between our cells also, water is there. Okay. And in the blood, again outside the cell. This is also outside the cell only. In the blood, what is there? Plasma is there. Okay. So now, mainly let's classify where water is present inside the cells. That is intracellular fluid. Intracellular. Okay. That and extracellular fluids. Extracellular. So there are intracellular fluids and extracellular fluids. How much is the intracellular fluid, sir? Intracellular fluids are more or extracellular fluids are more? Sir, intracellular fluids are more. That is 2/3 of our body fluids. Sir, out of this 42 liters, 2/3 maximum fluid is present within our cells. 2/3, that is almost 28 liters. Out of that 42, 28 liters are the intracellular fluids. 1/3 is extracellular fluid. 1/3 is ECF. Okay, extracellular fluid. How much? ECF is how much? 1/3. 1/3 means how much? Almost 14 liters. Okay. Now, this extracellular fluid, where this extracellular fluid is where present? Look at here. Carefully, sir. Look at here. Sir, extracellular fluid is present between the cells. Also, the extracellular fluids are present in the blood vessel, that is plasma. So, let's write the same thing. So, extracellular fluids are further classified into, okay, ECF is further classified into ECF, extracellular fluids, intracellular fluids, ICF. Okay. ECF is further classified into, see, this fluid which is there between the cells, this fluid which is there between the cells, this is called as interstitial. Okay, interstitial fluid. And the fluid which is present in the blood, that is called as plasma. Who is more? Okay, who is more? Whom do you think is more, sir? Okay, interstitial fluid is more or plasma is more? So 3/4 is interstitial fluid, means more. Interstitial fluid is more, and plasma is just 1/4. Plasma is just 1/4. In one of the exam, this question was asked. Are interstitial fluid? Okay, interstitial fluid. It is how much of your total body weight? How much of your total body weight is your interstitial fluid? That is 15%. Okay, 15% of your total body weight is the interstitial fluid. This is like, once long back this question was asked, but in recent exam, this question was there. So how much is the plasma? Your plasma is there, no? You are having the plasma. How much of your total body weight is the plasma? 5%. 5% of your total body weight is plasma. Okay. So out of your body weight, if you are 70 kilos, 5% is plasma. Okay. Out of that 70 kilos, 5% is because of plasma. So with this, the classification of the total body fluids is completed. ECF, ICF. ICF is more. In ECF, in extracellular fluids, there is interstitial fluid as well as plasma. 5%. This is MCQ. This is an important MCQ. 5% of the total body weight is plasma. Okay. Now, next, what kind of questions can be asked? So, total body water measurement. How to measure it? Total, some single liner. This topic is single liner topic. Total body water measurement. Total body water measurement. How much water is there? So the principle which is used, the method which is used to calculate the body water is called as Stewart-Hamilton method. The method is called as MCQ. Okay, Stewart-Hamilton method. Okay, Stewart-Hamilton method. This Stewart-Hamilton method, how it works? What is the principle, sir? What is the basis for the Stewart-Hamilton method? It is based on indicator dilution principle. Okay. Okay. So indication dilution principle, which means into your body, some indicator will be injected into your body based on how much it is getting diluted. If more fluid is there, the indicator will be more diluted. If the less fluid is there, the indicator will be less diluted. So based on the dilution of the indicator, you can estimate how much body fluid is there, how much ECF is there, how much ICF is there, how much plasma is there. Based on the indicator, see, simply you are injecting some indicator, indicator into the body. If you are having more fluid in the body, the indicator will be more diluted. If the indicator is diluting less, you will say there are less fluids. So total body water measurement is based on indicator dilution principle. So what are these indicators? That's the question. Okay. So let me write here. To calculate the total body water. Okay, let me write in this way. Sir, there is deuterium oxide. Deuterium oxide. What is this deuterium oxide? T2O. Okay, deuterium oxide. Sir, this is the indicator. Okay, what is this? This is the indicator. So this deuterium oxide is the indicator. It is used to calculate which body fluid? Total body water. Total body water ni calculate cheyadaniki. Okay, to calculate the total body water, we use deuterium oxide. Next, inulin. Okay, inulin, mannitol, sucrose. These three things are used to calculate ECF, extracellular fluid. Extracellular fluids. Okay, extracellular fluids are how much, sir? The 1/3 thing. Okay, extracellular fluids, 1/3. How to calculate the extracellular fluids? By injecting inulin into the body. Next, radio labeled albumin or Evans blue dye. Evans blue dye. Both these things, radio labeled albumin or Evans blue dye, is used to calculate plasma. Okay. And total blood volume. Total blood volume. How much is the total blood, not the plasma, total blood volume? It is calculated by using which indicator? Chromium tag RBC. Chromium tagged RBC. So chromium tagged RBCs are used to calculate blood volume. So this is a famous question, famous topic for your FMG. Recently, I have never seen a question. Recently, I haven't seen a question, but long back, like long back means like 3-4 years back, like at that time, 2017, like that area. This question was there. Okay, the question was into how to calculate the blood volume by using chromium tagged RBCs. Plasma volume is calculated by, this is the question which was asked. Evans blue dye is used to calculate plasma volume. Okay. And okay, let me tell you, let me show you one more thing. To calculate the blood volume, what is the formula? This is also a question which was asked. Okay. The formula is plasma. Okay, plasma divided 1 minus hematocrit. Okay, 1 minus hematocrit. Plasma divided by 1 minus hematocrit. How much is your normal plasma? Can you tell me? Sir, normal plasma will be somewhere around 3 liters. They will give you in your exam. They will give you in your exam. Okay. 1 minus hematocrit is how much? 0.4. You know it. Okay. 0.4 or 0.45 is your hematocrit. Okay. So 3 divided by 0.6. Okay. Something like that. So it will be somewhere around how much? 5 liters. Okay. So you can calculate the blood volume, something like that. So anything is left over in let me just check. Let me just check anything I have left over in total body fluids. Yeah, one thing is there. See, when you are getting old, okay, when you are getting old, for example, with aging, let me write with aging. Okay, you are getting aged, means you are getting old. So what happened to your total body fluids? Your total body water decreases. Your extracellular fluids decreases, but your intracellular fluids increase. Remember, this is the question. When you age, okay, when you age, which fluids increases? Intracellular fluids increases. When you age, intracellular fluids increases. Okay, there is one time, okay, there is one time in your life where there is one period in your life where the extracellular fluids in your body is equal to the intracellular fluids. We know intracellular fluids are always more. Intracellular fluids are always more. But there is one time in your body where the extracellular fluids and intracellular fluids are in 1:1 ratio. Equal. Which time? Which time, sir? 1:1. Any idea? During 3 months. When you are a 3-month baby, okay, when you are a 3-month baby, your intracellular and extracellular fluids are equal. Okay, that's it. With this topic is also completed. Okay, from this entire topic, if you want to know one thing, plasma accounts for 5% of the total body weight. Okay. Next, one more. Sorry, recently, in recent exam also this question was there. Okay, recent exam, not the not just the 20 days back. Recent exam. Look, see, this is your intracellular fluid. Intracellular fluid. This is the extracellular fluid. Okay, who is more in the intracellular fluid? Most of the students know this. Who is more in intracellular fluid? In intracellular fluid, sir, potassium concentration is more potassium. Okay, who is very much less in the intracellular fluid? Who is not there in the intracellular fluid? This is the question. Calcium. Calcium is very less in intracellular fluids. Okay, then who is more in the extracellular fluid outside the cell? Who is more? Okay, extracellular fluid, that is ECF. ECF में कौन ज्यादा है? Who is more in the ECF? Sodium. Sodium is more in the extracellular fluids. Intracellular fluids, potassium is more. Question asked is, which ion concentration is the least in the ICF? Calcium concentration. Okay. So within the cell, look, within the cell, calcium is stored in, see, all the calcium, okay, it is stored in a special locker. Calcium is stored in a special locker, sir. It's not there in the cytoplasm. It's not there in the fluid. All the calcium, it is there in a special locker. That locker is nothing but endoplasmic reticulum. Calcium is stored in endoplasmic reticulum or sarcoplasmic reticulum, you can say. Okay, so it's in the okay, calcium is stored in endoplasmic reticulum. Okay, calcium is stored in endoplasmic reticulum. That's it. Or sarcoplasmic reticulum. Okay, in the muscles, it is called as sarcoplasmic reticulum. So done. 4 topics are completed. One, what you are left with? Now we are left with. Okay, now we are left with muscle physiology and nerve physiology. Okay, cell membrane topic ho gaya, sir. Cytoskeleton done, cellular transport done, body fluids done. Now we have to discuss muscle physiology and nerve physiology. But before discussing that, now just take a 5 minutes break. After the 5 minutes break, we can continue with the muscle and nerve physiology. Is that okay, guys? 5. Okay, 5 years. Last 5 years PVQs, do it. Okay, last 5 year PVQs, do it. Okay, last 5 year PVQs. 5 years means 10 exams. 5 years means 10 exams. Okay. Yes, FMG is enough. FMG is enough. If you can do NEET PG, that's excellent. Okay, at least last 5 year PVQs, do it. Okay, in the right now these days in the like online platforms whatever are available, I don't want to specifically promote something. All the online platforms, they have the PVQs. Okay, PVQs are there. So once go through the FMG last 5 year FMG PVQs. For example, say physiology questions, how many questions will be there? And on average 10 questions will be there in one exam. Last 5 years means 100 questions will be there. Okay, yearly 20 questions will come. No, June attempt, December attempt. So that's it. Okay, do those 100 questions. Okay, from where we can do? We can do it from the online platforms like Repladder, Marrow, Cerebellum is there, Doctors is there. All these things are there. You can do from them. Okay, so now let's take a break. Now what's the time? 10:30, right? Let's take a 5 minutes break. Guys, can you see me? Yeah, I came back. I came back. So we are about to end. So what we are left with? We're left with muscle physiology. Okay, muscle physiology. Now, first, let me share this PDF separately. Okay, let me share this PDF separately. Muscle and nerve physiology. Let me wait. See, I'm sharing right now because last time one PDF was missing. I have I taught students and that PDF I don't know accidentally it missed. So students was sir, that PDF was gone. We haven't received that PDF. So that's I don't want to have that issue this time. So I'm sharing. This is general physiology part 1. General physiology part 1. Set. So muscle physiology. Now take the heading. Now come to the slide. Muscle physiology. Sir. Important points in muscle physiology. Skeletal muscles. Guys, look. If you look at a muscle, this is the muscle. Okay. Now, see, this is the muscle. Inside the muscle, what do you have? Sir, inside your muscles, there are a lot of fascicles present. Okay. Inside the muscle, what is there? Fascicle is there. Okay. Done. Now, inside the fascicles, see, there are muscle fibers. Okay. Muscle fibers. These muscle fibers are the real cells. This muscle fiber is a one muscle cell. These are the myocytes. These muscle fibers are the myocytes. Inside the myocytes, you have myofibrils. These myofibrils are nothing but the actin and myosin filaments. Okay. So these myofibrils, they are nothing but actin and myosin. Okay. These are actin and myosin. So first write this thing. So first you have fascicle. Inside the fascicle, you have muscle fiber. Inside the muscle fiber, you have myofibrils. Myofibrils are made up of myofilaments like actin and myosin. Okay. The same thing. Let me show you here also. Skeletal muscle, sir. You are having skeletal muscle. So inside the skeletal muscle. Okay. So inside the skeletal muscle. So this is your muscle fiber. Muscle fiber. Now, these muscle fibers, what do they have? I have said you, they have myofibrils. Look at this myofibril. Sir, myofibrils are made up of what? Just now I have explained you. Myofibrils are made up of, see, these things are called as actin. Okay, what I'm highlighting here, myofibrils are made up of actin. See, the blue color things are the actin. And here, these pink color things which I'm highlighting, these are what? Myosin. Actin and myosin are present in muscles, true. They are present in myocytes. This actin and myosin, they are present in myocytes. Aha, okay. Okay. Now, what is the functional unit of a muscle? Okay. Now, little bit detailed things. What is functional unit of a muscle? Okay, let me write here. Functional unit. Functional unit. The functional unit of a muscle is called as a sarcomere. Okay. The functional unit is called as what? Sarcomere. Sir, what is sarcomere? You will have it down. Sir, sarcomere means, just look at this myofibril. Now, here there is a Z line. See, there is Z line. Here you can see the Z line, right? This is a line. Z line. Okay. Now, the area between the two Z lines is called as this area. Okay, this area between the two Z lines, that is called as a sarcomere. Okay, let me just enlarge the same thing so that it will be a little bit more clear. Okay, look at this. Sir, on the periphery, What do you have on the periphery? What do you have, sir? This Z line, or you can say Z disc. Okay. In between these two Z lines, you have actin. These filaments are what? Sir, actin filaments. Okay. It's the same thing. I'm just enlarging and I'm showing you. Sir, what is this? Actin, actin, actin. And what is there in the center? So what is this one? This is myosin heavy chain. This is myosin heavy chain, thick filament. There is thin filament. This actin is thin filament. This is thick filament. Okay. So, right. What is a sarcomere? Sarcomere, it is present between. Okay. Present between two Z lines. Okay. It's present between Z lines. The area present between the two Z lines is called as sarcomere. In the sarcomere, what do you have? In the sarcomere, you have thick filament. MCQ, you have the thick filament and you have thin filament. Thick filament is myosin. Thin filament is actin. Okay, thin filament and thick filament MCQs. Now, already I have told you, okay, myosin, not actin. Myosin is a motor protein. It moves. It moves. It moves. It's a motor protein. Why it is motor? I will explain you. Motor protein. Okay, sir. It's a motor protein. Understood? Now, myosin and actin in the muscle. See, myosin, it will move, right? Just now I told you, myosin is a motor protein. Okay, it moves. It moves. So it uses energy or not? Yes. So where that energy is utilized, let me show you a little bit, more detail. Sir, this is myosin. Okay, look here. Sir, what is this filament? Myosin filament, thick filament, myosin filament. Now, in the myosin filament, are you able to appreciate, sir, myosin heads are there. There are these things, say. These are called as myosin heads. These myosin heads, they break the ATP. They uses the ATP. They will go and bind with the actin. They will go and bind with the actin and they will pull the actin. They will pull the actin. That will cause the muscle contraction. These myosin heads, by breaking the ATP, by using the ATP, they will go and bind with the active sites on actin. They will go and bind with the active sites on actin and they will pull the actin. Okay, from both the sides, they will pull the actin filaments. So that will cause muscle contraction. So for now, what is the important point we should know? Myosin have, what does it have? Myosin have myosin heads. Okay, myosin head. So what is the importance of myosin head? Myosin head may ATP will be broken down. So myosin head have ATP is activity. So myosin head have ATP is activity. MCQ. Okay, ATP is activity is seen in actin. No, myosin. No, myosin head. True. Okay. Now here, actin, it is attached with where? Look, sir, here carefully. Actin, in this diagram again, let me show you with more clarity. Sir, this is actin, right? Okay, sir, this is actin. These filaments are actin filaments. Sir, actin filaments are attaching with what? They are attaching with Z line. Actin filaments are attaching with, see this Z line here, here, here. So actin is attaching with Z line with the help of, okay, actin attachment to Z line, right, with the help of something called as alpha actinin. Sir, is it important? That's the question asked in FMG exam, right? Actin attachment. I will show you the questions also. Actin attachment with Z line. With the help of, actin is attaching to the Z line, right? With the help of, or actin attachment to the Z line to alpha actinin. Okay, alpha actinin. Okay, alpha actinin. Then myosin, is it attaching to, okay, myosin, is it attaching to Z line? Okay, so that's also, which was the question. Myosin attachment to Z line, is it attaching? Look, sir, here carefully. Sir, A kya hai? This is myosin in the center. This is myosin. Is it attaching to Z line? Yes, it is attaching to Z line. See, there is a protein. With the help of this protein, there is a spring-like protein. With the help of this protein, it is also attached to Z line. See, there is this protein which is attaching the myosin to Z line. What is this protein? Now that protein, okay, that protein is called as what? See, here it was given. This protein, spring-like protein, is called as titin. Right. So actin ho gaya, myosin. Myosin attachment to. Okay, myosin attachment with Z line with the help of titin. Now regarding titin, MCQs will come. Sir, titin is the largest protein in the humans. Okay, what is the important point about the titin? It's the largest protein. Not largest gene. Largest gene is the dystrophin gene. Largest protein. Okay, titin. Second thing, titin, how it is looking like? Have you seen titin? It looks like a spring. So this is called as titin is called as muscle spring. Okay, titin is called as muscle spring. Okay, so they will ask you, what is the function of titin? Titin is responsible for the elasticity, elastic nature of the muscles. Okay, elasticity of the muscles. Next, anything important about the titin? Titin, elasticity, muscle spring, largest protein. Enough. These are the important points about the titin. Enough. Okay. Now, one more thing which I want you to know. There is something called as nebulin. So, what is nebulin? Okay. Sorry. Now, let me show you the same thing. Same sarcomere, but little bit in detail. Same sarcomere, little bit in detail. Look at this. See, the same thing, but extra points. What is this one? What is this one? Sir, this is actin filaments. You know it? Actin, actin. This is actin. This is actin. Okay. Now, on the actin, look carefully. Look on the actin. There is a protein. See, look here. Okay, this green color thing. There is a protein. Okay, this one. Which is spanning throughout the length of actin. Okay. A protein which is spanning means going throughout the length of actin and maintaining the length of actin. It maintains the length of actin filaments. What is that protein called as? Nebulin. So, right, nebulin. Nebulin is there on actin. Nebulin is present. Question asked, nebulin present throughout. Nebulin present throughout the length of actin and maintains the length of actin. Maintains length of actin. Okay, so done, sir. Next, what else I need to teach you? What else I need to teach you? The topic is proteins in sarcolemma. Okay, what are the proteins which are present in sarcolemma that I have to teach you? Okay, now take the heading proteins in the sarcolemma. Now this one. Okay, just let me take that. Take the heading proteins in sarcolemma. Sarcolemma means what? Muscle cell membrane only, no? Cell membrane. Okay, muscle cell membrane. You already know it. Look at this. So this is your muscle ka cell membrane. This is your skeletal muscle membrane, sir. Skeletal muscle membrane. Okay, skeletal muscle membrane. Now in the skeletal muscle membrane, see, this is one. Okay, this is a skeletal muscle membrane. This is cytoplasm, you know it. This is extracellular. Okay, this is outside. Now look carefully. In the muscle cell membrane, there are certain proteins present. Okay, there are certain proteins. See, there is this one protein present. Look, see here. This is one protein. There is other protein present. This is alpha, beta, gamma, delta subunits. One more protein is there. See, there is one more protein with the alpha, beta subunits. Okay. So what are these proteins? Let me go one by one. The first protein which I want you to know for your exams is dystrophin. Okay. Dystrophin. Dystrophin. I have already explained you Duchenne's muscular dystrophy. Duchenne's muscular dystrophy. Dystrophin protein is a peripheral protein. I will show you. Don't worry. Dystrophin. Second protein is called as syntrophin. Okay, syntrophin. Okay, dystrophin, syntrophin. Third protein, dystroglycan. Sarcoglycan. Okay, sarcoglycan. Dystroglycan, sarcoglycan, and final thing is sarcospan. SCR, sarcospan. Okay. Now, let me show you these proteins one by one. Okay, let me show you these proteins one by one. Here, look here. So there is something called as dystroglycan. You should tell me. So there is something called as dystroglycan, which is having alpha subunit as well as beta subunit. Now tell me, is it an integral protein or peripheral protein? Sir, it is present outside as well as in the membrane. It is also coming in. So it is a transmembrane protein. It is present throughout. So dystroglycan, sir, it is not a peripheral protein. It is integral protein, right? It's an integral protein. IP. Dystroglycan is an integral protein. Okay. Next. Sir, there is sarcoglycan. See, alpha subunit, beta, gamma, delta subunit, sarcoglycan. So sarcoglycan, is it integral protein or peripheral protein? Sir, it's there outside, it's there inside, it's there throughout the cell membrane. It's there throughout the cell membrane. So that is again integral protein. So sarcoglycans are also integral proteins. And the last one, this is the sarcospan. Okay, sarcospan, it is also integral protein. Okay, here the labeling is not there. That is the sarcospan. Okay, so right, it is also integral protein. Integral protein. Now, the real important things. Dystrophin. Where is the dystrophin present, sir? Look carefully. Where is dystrophin present? Sir, are you able to look? Sir, dystrophin, I have told you already in the general physiology. I have told you. Sir, dystrophin is a peripheral protein. So that's why, see, this dystrophin protein, it is only attached to one side of the cell membrane. Okay, it is attached to the dystroglycans. It is only present on the one side of the cell membrane. Okay, so dystrophin is peripheral protein. And also see the syntrophins. So syntrophin molecules also, syntrophin also is present only on the one side of the cell membrane. Okay, so right. So dystrophin is star mark, peripheral protein. Syntrophin is also a peripheral protein. Okay, peripheral proteins. So for as a special, let me write in a different color. These are peripheral proteins. Okay. Now dystrophin, look, it is attached to what? See, within the cell, this is also question asked. Within the cell, this is the NEET PG question. Within the cell, the dystrophin, look, it is attached to what? Can you tell me? Can you look and tell me it is attached to what? I have told you, sir, your actin is also cytoskeleton. Okay, actin is a microfilament. Actin is there in each and every cell. Actin is there in each and every cell. So see, dystrophin, it is coming and attaching to cytoskeletal actin. Okay, dystrophin is attaching to cytoskeletal actin. Okay, that's an important point, right? So dystrophin, NEET PG question, attaches to cytoskeletal actin. This is cytoskeletal actin, not the actin and myosin in the sarcomere, not that actin. This is a cytoskeletal actin. Okay, so with this, I have taught you ABCDs. These are the basic things. Okay, now after this, let me tell you different proteins. Sarcolemmal proteins. The proteins in the cell membrane are completed. Okay, now let me discuss with you regulatory proteins. Take the heading regulatory proteins. Regulatory. Okay, let me take it in the new slide if possible. Yeah. Regulatory proteins. So what are these regulatory proteins? Okay, regulatory proteins. They regulate the muscle contraction. See, they regulate the muscle contraction. What are they? Number one is troponin C. troponin C. I will show you troponin C. And second one is tropomyosin. Troponin C and tropomyosin. These are the regulatory proteins. So troponin C, in the name itself, it's there. Question which was asked in the FMG exam. Troponin C, it binds with what? It binds with calcium. Okay, troponin C binds with calcium. Tropomyosin. Tropomyosin binds with what? Tropomyosin binds with, sorry, not binds with. Tropomyosin का function है. Tropomyosin, it covers active sites on actin filaments. Okay, let me show you this thing. I'm drawing one actin filament. Okay, I'm drawing one actin filament. Look at here. So this is actin. Imagine this is actin. Okay. Now here is the myosin. Let me draw the myosin in a thick form. This is myosin. Okay, actin and myosin. On the actin, what are there? On the actin, there are active sites present. Okay, on the actin, these are the active sites. Okay, first let me write. This is actin. This one is what? This is myosin. Normally, during resting time, I'm talking about the resting time. So myosin, what does it have? Myosin have its heads, myosin heads. Okay, these myosin heads, they can go and bind with what? They can go and bind with active sites. They will go and bind with the active sites. Okay, but there is a molecule called as a tropomyosin. Okay, there is a molecule called as what? Tropomyosin. What this tropomyosin is doing? Look, so this is a tropomyosin. What it is doing? The tropomyosin is covering the active sites so that unnecessarily muscle contraction will occur. No. So who is covering the active site? This is active site. Right with me, active site. So these active sites are covered by this molecule. There is a protein which is covering the active sites so that the myosin heads is not coming and binding during normal restful state. So this is tropomyosin. This is tropomyosin. Now, this tropomyosin, it is attached with, look, let me take brown color. Now this tropomyosin, look, it is attached with one more protein. This is called as troponin C. Tropomyosin is attached with what? Troponin C. Now, when you want to contract the muscle, see, when you want to contract the muscle, first what happens? Calcium is released into the muscle. Calcium will come and bind with the troponin C. See, calcium is coming and binding with the troponin C. Now you know the story. When calcium is binding with the troponin C, it will move the tropomyosin away. Now the tropomyosin, what will happen to the tropomyosin? The tropomyosin, it will be moved away so that these myosin heads will go and bind with the active sites. The myosin heads will go and bind with the active sites. Okay. So this, I will explain this again when we are discussing the muscle contraction. I will discuss this again. But the point which I want you to know is, sir, when you want to contract the muscle, calcium is released. Calcium will be bind with the troponin C. When calcium binds with the troponin C moves the tropomyosin away. Exposes the active site. Exposes the active sites. So that this myosin heads will go and bind with the active sites and muscle contraction will occur. Okay. So these two simple things, these two regulatory proteins, clarity hai na hai. Troponin C, it binds with calcium. Okay. Tropomyosin, it covers the active sites on actin during rest. Okay, during rest. That's also important. Let me write during rest, which means your muscles are not contracting during rest. Okay. So shall I continue? Do you have any doubts? Let me check. So do you have any doubts? Now, after this, I will directly start the muscle contraction topic. So, no doubts, right? So, let's continue. Now, take the heading contraction of muscle. Contraction of muscle. That is sliding filament theory. Sliding filament. Sliding filament means what? The actin filament is sliding on myosin. Actin filament is sliding on myosin. So sliding filament theory. So what is the sliding filament theory? What happens? According to the sliding filament theory, look, what happens? I will tell you one by one. First of all, draw your muscle. Sir, this is my muscle cell membrane. Look. Okay. This is the cell membrane of your muscle. See your muscle cell membrane, it is having these invaginations. Okay, it is having what? These invaginations. Means the muscle cell membrane. It sometimes it is going into the cell within the cytoplasm. This is the cytoplasm. Cytoplasm. Okay, this is the muscle cell membrane. Now, I have already taught you, sir, in the muscle fibers, what do you have? You have actin and myosin. Let me draw the actin and myosin here for easy understanding purpose. Let's make it as easy as possible. Here is your Z line, one Z line. Here will be the other Z line. So to the Z lines, who is attached? To the Z lines, actin is attached. Okay. Draw this with me. Actin, 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 actin. Okay, these are the actin filaments. Now, here in the always in the center of the muscle, always in the center of the sarcomere, what is there? M line is there. M line is in the center. Sides, these are Z lines. Okay, this is one Z, this is other Z. So for students who doesn't know that M line, look, in the center of the sarcomere, there is M band or M line. M line or M band is there. Okay, in the center, to which myosin is attached. Okay, let me draw the myosin now. Let's draw the myosin in blue color. Myosin is a thick filament, so let's draw it a little bigger. So here is the myosin. Sorry, myosin. Here is the myosin, okay? Now, let's see one by one what happens. So, here is the alpha motor neuron. Look, here is the alpha motor neuron. So, alpha motor neurons, you know, they will cause the muscle contraction. Here is the alpha motor neuron. Okay. This is alpha motor neuron or the lower motor neuron. What is this invagination? So the cell membrane, it is coming into the cell, right? The cell membrane is coming into the cell. So this is the place where the muscle cell membrane is coming into the cell. So what is this area called as? Can anyone tell me what is this area called as, sir? What is this called as? What is this invagination called as? This is called as T-tubule. Okay, this area, the place where the cell membrane is going into the muscle, this area is called as, right? Very important, T-tubule. So T-tubule is nothing but the cell membrane invagination. T-tubule. Okay, T-tubule. Okay. Next, there is one more tubule which is called as L-tubule. Okay, what is this L-tubule? Look here carefully. Sir, within your muscles, there is L-tubule. Okay, L-tubule is present within your muscles. Sir, what is this L-tubule? L for longitudinal, T for transverse. Okay, longitudinal. Longitudinal tubule is nothing but, you should tell me, sir, inside the longitudinal tubule, see what is there. See what is there. Sir, lots of calcium is there. Lot of calcium is there, especially in this region called a cisterna. In the cisterna region, lot of calcium is there. Okay, so can you tell me what is this L-tubule? The L-tubule is nothing but, it is nothing but sarcoplasmic reticulum. So, right, it is sarcoplasmic reticulum. This is sarcoplasmic reticulum. Now, let me teach you about some channels. Okay, now let me teach you about the channels which are highly integrated with your anesthesia also. In anesthesia also, these things will come. There is a channel which is present on the T-tubule. The channel name is called as DHPR. Okay, this channel which I am showing you here, which is present on the T-tubule, that is called as what? DHPR channel. Okay, let me write here. This is a DHPR. I think this is a DHPR, dihydro pyridine receptor calcium channel, dihydropyridine receptor calcium channel. It's actually DH, like it acts like a hand. Okay, I always think like it acts like a hand. It is going to act like a hand, sir. Why, I will tell you in a minute. One more channel which is present on the L tubule. Now there is a different channel which is present on the L tubule. Let me draw it with a different color. So this channel which I am showing here in okay, let me take which color now. Let me take brown color. So this channel which I am showing here, this is called as RYR channel. Okay, this is RYR. RYR. So RYR stands for ryanodine receptor. Okay, ryanodine receptor channel, DHPR, RYR. Direct questions. RYR channel is present on L tubule. DHPR channel is present on the T tubule. Okay, is that clear? Now, see, DHPR it is having is normally RYR channel is closed. It is closed. RYR channel it is closed. DHPR channel it is like this. Okay, mechanically it's having a hand-like thing. I will explain what happens. First, let's start from here. Okay, let's start from here. Sir, now you want to contract your muscle. So alpha motor neurons are activated. Okay, your motor cortex is activated. Upper motor neurons are activated. Upper motor neurons are controlling the lower motor neurons. So now lower motor neurons are going to release acetylcholine. Now what the lower motor neurons are doing? Lower motor neurons are releasing the acetylcholine into this neuromuscular junction. What is the junction? Neuromuscular junction. Okay. Now in the neuromuscular junction, what do we have here? Sir, in the neuromuscular junction, we have the receptor. What is this receptor? This is NM receptor pharmacology. Okay, NM type of receptor. NM type of the receptor which is present in the neuromuscular junction. NM, neuromuscular. This is the nicotinic receptor. Nicotinic receptor. N for nicotinic receptor, which is present on the muscle. Now this acetylcholine, look, it is coming and it is binding with the nicotinic receptor. When it binds with the nicotinic receptor, okay, when it binds with the nicotinic receptor, actually nicotinic receptor is a channel. It will allow the sodium to come into the cell. So whenever acetylcholine is binding with the receptor, who will come into the cell? I am showing here separately. Sodium ions will come into the cell. When sodium is coming into when lots and lots of sodium is coming into the cell, now the cell membrane will undergo depolarization because of the sodium, which is a positive charge. The depolarization is spreading across the T tubule. Now the depolarization is also spreading across the T tubule. When this depolarization reaches the DHPR channels, now DHPR channels mechanically, see, look at this. Look at me. Now DHPR channel, the DHPR channels, they will go and mechanically open the RYR channel. Imagine this is the DHPR channel. This is the RYR channel. The DHPR channel will go and it will open the RYR channel. So the RYR channels, they are opened mechanically. Okay, mechanically this opening will occur. So what is happening? Now twist will occur. Twist. Now the channel is going to open. This is called as electromechanical coupling, because first electrical activity is happening. Because of this electrical activity, now the DHPR channel, it will open the RYR channels. Okay, so let me write here. This is called as electro. Okay, this event is called as electromechanical coupling. Questions asked. Okay, so what is happening during electromechanical coupling? Because of this electrical event, okay, because of the depolarization, DHPR channel opens. Let me write here. The DHPR channels opens RYR channels. Okay, now tell me, when RYR channel open aite, if RYR channel is opened, you know the story. When RYR channel is opened, okay, let's look here. Now the RYR channel is opened. It is open now. Now who will come out? Now for the first time, calcium will come out. Now you know the story. Once calcium comes, calcium goes and binds with troponin C. Troponin C, what it will do? Troponin C, what it will do? Troponin C moves tropomyosin. Myosin. Troponin C moves the tropomyosin away. So what happens? Active sites are now exposed. Active sites are exposed. Right. Active sites exposed. Now, when the active sites are exposed, the myosin head will go and bind with myosin heads. Myosin heads will go and bind with the active sites, and by using the ATP, they will pull the actin. They will pull the actin. Okay, they will pull the actin so that muscle contraction occurs. Okay, so this is what I want you to know. Okay, so events, one by one event. So first, when alpha motor neurons are firing, they will release the neurotransmitter acetylcholine. Acetylcholine is released into the neuromuscular junction. Now, when acetylcholine binds with the nicotinic receptors, sodium influx occurs that causes the depolarization of the cell membrane. Because of the depolarization of the cell membrane, the DHPR channels opens the RYR channels. Okay, the DHPR channels open the RYR channels. That is called as the electromechanical coupling. Because of the electromechanical coupling, the calcium is going to be released from the sarcoplasmic reticulum. The calcium helps in muscle contraction. You know the story. Calcium binds with the TNC, troponin C. Troponin C moves the tropomyosin away. Active sites are exposed, and you know the story. Muscle contraction occurs. Do you know what was the question which was asked? For electromechanical coupling, calcium is required. That's the statement which was asked in the FMG exam. Is that true? No. For electromechanical coupling, you require the sodium, not the calcium. Because of electromechanical coupling, look, because of electromechanical coupling, which ions are released? Calcium is released. Okay, so right here, electromechanical coupling releases calcium. Okay, when you are doing the questions from different platforms, you will find these questions. Okay. So if you say, sir, we understood, I will tell you a few more important MCQs. Why is Satish general physiology boring? So hope it is clear. Now let's continue. Sir, there is a condition in which this RYR channel, it is overactive. There is a gain of function mutation. Okay, there is a gain of function mutation in the RYR channel. Means RYR channel unnecessarily it is opened. When it is unnecessarily opened, more calcium is getting released. That will cause unnecessary muscle contraction. Whenever the muscle contractions are happening unnecessarily, that increases the body temperature so much. Okay, so that condition, do you know what is the condition? So if RYR channels, let me write here, RYR channels, they got what? Gain of function mutation. They got gain of function mutation. Means now they are working more, they are functioning more, they are opening for more time. So RYR channels, they have a gain of function mutation. So that can cause a disease called as malignant hyperthermia. Because more muscle contraction, more body temperature is going to produce malignant hyperthermia. Okay, so in malignant hyperthermia, that's the problem. Now, some patients have this mutation, RYR channel mutation. Okay, gain of function mutation in the RYR channel. See, in me also, for example, RYR channels are mutated. In me also, RYR channels are mutated, but usually I don't have any problem. But when I use certain drugs, anesthetic agents like desflurane, this is coming in anesthesia also. Okay, desflurane. Okay, isoflurane, succinylcholine. This is question. Okay, so they can precipitate the malignant hyperthermia. Okay, normally, yeah, RYR channels are mutated, but they don't show that much effect. They don't cause that much problem. But in these people where the RYR channels are mutated, if you use certain drugs like desflurane, isoflurane, succinylcholine, Okay, they cause more symptoms. They will immediately cause malignant hyperthermia. So question is, malignant hyperthermia is seen with the usage of which anesthetic agents? Isoflurane, desflurane, and which muscle relaxant? Succinyl choline. Okay. So how to treat this condition? Malignant hyperthermia. How to treat this condition? Problem is with which channel? Ranodine receptor sodium channel, like ranodine receptor channels. Ranodine receptors are over functioning, so block them. So the treatment for this condition is dantrolene. Dantrolene sodium. What is this dantrolene sodium? It's a RVR blocker. It's a ranodine receptor blocker. It's a ranodine receptor blocker. Okay. Malignant hyperthermia. Done. Now, next, what else I want you to know is, sir, muscle contraction complete ho gaya, sir. Muscle contraction completed. Now, whatever the calcium came out, it have to go where? It have to go where? And again, it have to go back. Again, it have to go back. So, the point which I want you to know is, the calcium should have to go back. The calcium should have to be sequestered back. For that purpose, you have one more protein here. There is a protein through which the calcium is going back. Okay, there is a protein through which the calcium is going back. So that protein is called as SERCA. MCQ. SERCA. Okay, SERCA. SERCA means sarcoplasmic endoplasmic reticulum. See, this is a sarcoplasmic reticulum, no? Sarcoplasmic endoplasmic reticulum. Calcium ATPase. By using the ATP, the calcium is again taken back. The calcium is again taken back. Okay. So, right here, SERCA. Okay. SERCA sequesters. Okay, SERCA sequesters calcium back into sarcoplasmic reticulum. Okay, so SERCA, it's a protein. It sequesters the calcium back into the sarcoplasmic reticulum. Now, can you tell me, sir, SERCA means sarcoplasmic endoplasmic reticulum, calcium ATPase. So, what kind of transport it is? What kind of transport? Calcium. What kind of calcium transport? ATPase. Primary active transport. Don't forget. Okay. Now, SERCA. Second question regarding SERCA. Sir, SERCA, is it helping in the contraction or is it helping in the muscle relaxation? SERCA, is it helping in contraction or muscle relaxation? Can you tell me? Sir, it is helping in muscle relaxation. Okay, calcium is going back. So, it is a relaxing protein. It helps in muscle relaxation. Okay, relaxing protein. So, done. Okay. So, I have explained you about the malignant hyperthermia because of the ranodine receptor mutation and SERCA. This is something normal, SERCA. Okay. Next, what else you should know? Now, you might think, sir, why you are teaching like, so many things are coming in the muscle physiology. Again, I'm telling you, see, one question will be there on your muscles. Okay, one question can be there on your muscles. 1000% pakka, you can expect one question from the gluts, the transport, gluts and SGLTs. One question will be there for sure, no doubt. The second highly important area is muscle only. The second highly important area is muscle. After muscle, you can expect question from the cell membrane topic, cell membrane and cytoskeleton. It's a one single thing, cell membrane and cytoskeleton. It's a one single topic. You can expect one question from there. So muscle is important. Okay. So look at here. Sir, in the recent NEET PG and INICT exam, the recent this year NEET PG and this year, like this year means 2023. Okay, the last NEET PG exam. The question which was asked is, sir, muscle is contracting. Yes, we know. See, this is actin. Okay, this is actin, sir. These are actin filaments. This is myosin. Okay, this is myosin. This is the myosin head. It breaks the ATP. Okay, we know it. It breaks the ATP. And this myosin head, it will go and bind with what? It will go and bind with active site. After binding with the active site, what it will do? It will pull the actin. It will pull the actin so that muscle contraction occurs. Okay. So these are the different stages. See, these are the different stages. But what they would love to ask repeatedly, what they would love to ask in the exam is, okay, what they would love to ask in the exam is, let me tell you. See, when the myosin head is pulling, see, when the myosin head, okay, when the myosin head is pulling the actin filament, okay, when the myosin head is pulling the actin filament, does it require any ATP? When the myosin head, when it is pulling the actin filament, that event is called as a power stroke. First of all, you should know that event is called as power stroke. What is happening during power stroke? See, during the power stroke, the myosin head bends. But does it require any ATP? No, it does not require any ATP. So, right. So, during power stroke, okay, no ATP is required. No ATP is required. Okay, no ATP is required. Second thing, during power stroke, okay, who is released? Look, when the power stroke is happening, ADP, okay, ADP is getting released. ADP and inorganic phosphate. Okay, first you should understand, sir. See, if you want the muscle to contract, just let me clear this. See, for the binding, okay, for the binding, you require ATP. Okay, see here first ATP is broken down. ATP is already broken down. See here ADP is attached. Still ADP is attached. Inorganic phosphate is attached. Now after breaking ATP, now the myosin head is going and binding here. So for attachment ke liye, you require ATP. Okay, attachment ke liye you require ATP. But during the power stroke, see what is happening. The ADP and inorganic phosphate. See, this ADP and inorganic phosphate are released. To be very frank, the actual release of ADP is leading to the bending. Release of ADP is leading to the power stroke. So, right, during power stroke, ADP and inorganic phosphate are released. Okay, ADP and inorganic phosphate are released. Okay, sir, done, completed. Now, after this, what should happen? Again, the myosin head, it should detach. Now, the myosin head, it should detach. Okay, from the active side, the after pulling, after like, the contraction, the myosin head should detach from the active sites. For that detachment purpose ke liye, again, you require the ATP. So, ATP is required for attachment and detachment, but not for the power stroke. Okay, not for the power stroke. So, see the fourth event, say a new ATP molecule, okay, attaches to the myosin, okay, attaches to the myosin head, causing the cross bridge detachment. This is called as a cross bridge. Okay, cross bridge means like, cross bridge means myosin attachment to actin. Myosin attachment to actin is called as cross bridge formation. So, if you want to break this cross bridge formation, if you want to remove the myosin from the actin, again you require the ATP. So, right, cross bridge detachment के लिए, okay, cross bridge detachment requires new ATP. So these things are highly important. So power stroke does not require any ATP, but for the detachment of cross bridge, okay, or cross bridge formation, cross bridge detachment, cross bridge formation, cross bridge detachment, you require the ATP. Okay, so understood? So these are the important points which I want you to know. So is that clear, guys? If it is clear, I will show you an electron microscopic image which was tested in the exam. I will show you that. Okay. Let me check if you have any doubt or not. So yeah, unnecessary. See, in malignant hyperthermia, there is excessive contraction. Also to decrease that contraction, we are giving the dantrolene sodium. See, if you use dantrolene sodium, I mean like no low dose, not high dose, low dose of dantrolene sodium. Okay, so it is going to block certain ranodine receptors. Not, see, for example, there are 1,000 ranodine receptors, maybe 400 ranodine receptors are blocked. So other 600 are functioning. No. Okay, Rasul, other 600 are functioning. No. So muscle contraction occurs, but decreases. Okay. Chalo. Revision. So this is the question which was asked in the exam. See, I might simply leave. I can say like, sir, this is enough, more than enough, but I don't want to leave anything. Okay. Means at least important topics I don't want to leave. At any cost, I have to complete the important topics. That's it. Even if you feel like, sir, it's like too much, I can't help, sir. So these are all previously asked questions. Okay, look at this. Organize the list of bands in the sarcomere from periphery to center. They gave this image-based question. Okay, they gave this image-based question. They will give you this electron image, like electron microscope. They will give you this electron microscope, and they will ask you, like what is which band, which band, which band. You just try once. You just try once. I will come in 1 minute. You just try once. Yeah. So now let me explain. Always, sir, always look in the sarcomere. Who is there in the periphery? In the periphery, there is Z. Who is there in the center? There is M in the center. Okay. Here, look. Now, this is Z. The Z lines. Z lines. These are the Z lines. Okay. If these are the Z lines, then what is there in the center? In the center, what line will be there? This is the M line. So, if someone asks you for arrange from periphery to center, first what should be there? Z, and in the center, it should start with, okay, look. It should start with Z. And what is there in the center? In the center, M should be there. So it should be starting with A and ending with B. Where it is starting with A, see, here it is starting with A and ending with B. So this is the answer, sir. This is the answer. But that's not enough. That's not enough. I want you to know more. I want you to know more. Look in this diagram. See, there is a place where, okay, there is a place where only actin is present. Look, there is a place where only actin is present. So this is the place where only actin is, see, actin. Okay. Okay. And there is a place where both actin and myosin is present. Okay, actin and myosin is present. So what is this one? Look, I'm dividing. Now I'm keeping now 2 new lines here. Okay, now 2 new lines I'm keeping here. So this place where, देखो, the place where both actin hai, myosin hai, actin, myosin, actin, myosin, actin, myosin. Okay, so this area is called as A band, A band, A band. Okay, so what is A band, my dear students? A band for anisotropic. Anisotropic, because of the presence of 2 filaments, it is anisotropic. Anisotropic means like under the polarized light, there is anisotropy. Okay, induku why? Because actin hai, myosin hai, actin hai, myosin hai, actin hai, myosin hai, actin again. So the area of the sarcomere where you have both actin and myosin is called as which band? A band. Okay, okay. Now in the A band, look carefully. In the A band, look carefully. There is an area where only myosin is there. Dekho. Here in the center, there is only myosin, myosin, myosin. There is no actin. So that area where only heavy chains are there, that area where only heavy chains are there, that is called as H zone. Okay. So now let me take this. Okay. Copy. And let me add this in the PDF. Paste. Yeah, here. Okay. So write H zone and A band. What are the important points which I want you to know regarding the A band? Write this with me. Write with me. A band. So A band means anisotropic. A band. It includes what? It includes both actin and myosin. A band. Next, what is H zone? What is H zone? H zone only myosin. Okay, H zone it's only about the myosin. H zone is only about the myosin. Then where only actin is present? Where only actin is present, sir? Look here, I have already taught you, sir. Here in this area, only actin, 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 actin filaments are there. So that area is called as I band. I band for isotropic, only isotropic. Okay, so right, I band, A band, I band. Okay, I band for isotropic, only actin. Okay, for those students who doesn't observe properly, look, I band may only actin is there. Okay, there is no myosin. Okay, so only actin. So tell me one by one. Now you look here, sir. Can you? I'm just going to show you the. I'm going to show you the region. You have to tell me which band or which line. You have to tell me, sir. What is this area? This area. For example, I'm marking this area X. I'm marking this area X. Sir, X here. Is it A band or I band or is it H zone or what is that? X region. Can anyone tell me? It's I band. Satish Kumar, it's true. It's I band because only actin is there. Yeah, Vishnu, Yadav, Roshni, you are all true. It's I band. Okay. Now, can you? This is how the questions will be coming up in your exam. So, if someone asks you what is this area, just let me erase this. What is this area? What is this area? In the center. Sir, in the center. What is this area? For if I give X. Sir, X may only heavy chains are there. So that is H zone. H zone. That is H zone. Aha, okay. H zone. Now, if I erase this and if I mark something like this. Okay, if I mark something like this. Look carefully. What is from here till here? What is this area? What is this area of the sarcomere? What is this area of the sarcomere called as? So this area of the sarcomere, both actin is there, myosin is there, actin is there, myosin is there. So this is A band. Ikkad nunchi ikkada varaku. From here till here, this is called as A band. Okay. So hope you understood the different areas: A band, H zone, M line, Z line, all these things. Okay. So in your exam, what they will ask you? Final thing. The final thing from the thing, what they will ask you is, when a muscle is contracting, you should tell me. When a muscle is contracting, think and tell me. When a muscle is contracting, the actin filaments will slide over the myosin. The actin will move and slide over the myosin. So what happened to the Z lines? The Z lines are coming near to each other. Z lines are coming near to each other. So right, when muscle contracts, Z lines, okay, approaches each other. Z lines approaches each other. Approach each other. Okay. Now, what about that H and I? H and I, they will ask you. H means, heavy, heavy thing. Okay. So that H band or H zone. Okay. H band. What happens? Decreases. Okay. Decreases. What happened to the I band? Okay. Or I band, like, isotropic band. Sir, I band size also decreases. Okay. I band, H band, I band decreases. But what about the A band? It is same. Okay. No change. Okay. Its length is not going to change. Okay. Its length is not going to change. How I used to remember, when I was a student, how I used to remember is, when sir was teaching, how I used to remember is, see, for example, imagine there is your friend. Okay. You went to some party, and there is your friend, for example, he is standing somewhere over there. Okay. Long distance, he is standing somewhere over there, and you saw him and he saw you. Okay. You saw him and he also, like, he have also seen you. Now, what you are going to say immediately? Hi. Okay. You are going to say hi, right? Hi. So I used to remember hi. So whenever you say hi to him, your friend, you are going to meet each other. You are going to go towards him, and he is going to come towards you. Because of that, what happened to the distance between you? Decreases. So something like that. Hi. So hi, saying hi is going to decrease the distance. In the same way, I used to remember hi H and I. Okay, H band, I band decreases. Okay. So with this, all points which you should know regarding the muscle physiology. Okay. In muscle physiology, like, a lot of, like, topics are there, like, tetanizing frequency, red muscle fibers, white muscle fibers. They're all needed for, like, INICT kind of exams, but not for FMGE. So leave it. These are enough. So muscle physiology done. If muscle physiology is done, in the next 15 minutes, we can do the nerve physiology and we can wrap up the session. And we can end the session. Is that okay, guys? The last topic, nerve physiology, is that okay? Even I want to wrap up the session because, like, even I am feeling really not good. Acid base is there. No, yeah, I will do that. I forgot. So shall we start the nerve physiology? In nerve physiology, what they will ask you? Let's make it as simple as possible for you. Take the heading nerve physiology. Nerve. Nerve physiology. What they will ask you regarding the nerve physiology? They will talk about the different types of cells in the nervous system. What are the different types of cells that are there in the nervous system? Okay, simple first, right? Sir, in the recent exam, they have asked ependymal cells. Ependymal cells. Sir, what are these ependymal cells in the nervous system? What they do? What are astrocytes doing? Astrocytes doing. What the Schwann cells will do? Schwann cells. Oligodendrocytes. Okay, oligodendrocytes. Next, microglial cells. Okay, microglial cells. What they do? Okay, ependymal cells, astrocytes, Schwann cells, oligodendrocytes. What is the function of these cells? See, ependymal cells, they are the lining cells. They are the lining cells of ventricles. So in your brain, you are having ventricles, no? The CSF, for example, say, let me show you in an easy way. Imagine this is your spinal cord. Okay. In the center of the spinal cord, what do you have? The central canal is there. For example, say here is the central canal through which the CSF is flowing. Now, the lining cells. Okay, these lining cells. These lining cells are called as ependymal cells. In the brain also, ventricles are there in which the CSF is present. So the lining cells are called as ependymal cells. Astrocytes, what do they form? They form blood-brain barrier. Okay, blood-brain barrier, astrocytes. They are the abundant cells. Okay, they are the most abundant cells. Schwann cells already we have discussed. What they form? Myelination. Myelination of central nervous system or peripheral nervous system? Peripheral nervous system. Oligodendrocytes, they also forms what? Myelination in central nervous system. Okay, central nervous system. The central nervous system is the brain and spinal cord. The neurons in the brain and spinal cord, the neurons and the brain and spinal cord are having the myelin sheath. That myelination is done by oligodendrocytes. Okay, the myelination is done by oligodendrocytes. And what are the microglial cells? Microglial cells are the macrophages in the brain. They are phagocytic cells. Phagocytic cells. Okay, they are the phagocytic cells. Okay. Now, the next topic which I want you to know is the types of neurons in our brain. How many types of neurons are there? Types of neurons. Let's write here. Types of neurons. First type is called as pseudo unipolar neurons. Pseudo unipolar neurons. Where are they present? Second, bipolar neurons. Okay, and multipolar neurons. Pseudo unipolar neurons, bipolar neurons, and multipolar neurons. See, the neurons which are there, the first order neurons, you know, right? The first order neuron, see, from the receptor, first order neuron takes this information to the dorsal horn. See, it is having two processes, one central process and one peripheral process. Okay, one central process means towards the spinal cord, and one peripheral process means towards the receptor. So such a type of neurons with the two processes, one central process and one peripheral process, such type of neurons are called as, okay, they are called as what? Pseudo unipolar neurons. Where they are present? They are present in dorsal root ganglion. You know it. I have said you. See, this area where the first order neurons are present, the cell bodies of first order neurons are present. That's called as a dorsal root ganglia, DRG, dorsal root ganglia. Okay, so right, the pseudo unipolar neurons are the first order neurons which are present in the dorsal root ganglia. Next, direct question: bipolar neurons, MCQ. They are present in retina and olfactory epithelium. By hearting things. In your retina, you have bipolar neurons, and olfactory epithelium also you have bipolar neurons. Multipolar neurons are present everywhere. Okay, most of your neurons are the multipolar neurons. Okay, done. So types of neurons. MCQ, which was asked previously, is in retina. Bipolar neurons are present. That's the question. Okay, now the topic, take the heading. The topic which I want you to know is action potentials in nerve. Okay, action potential in neuron. Let's discuss this under 1 minute. Okay, sir, this is your neuron, imagine. Okay, here is your neuron, sir. Okay, now what is the resting membrane potential of the neuron? MCQ asked. Minus 70 millivolts. This neuron is having an voltage of minus 70 millivolts. Okay, let's divide this neuron into 3 parts, for example, like this. Okay, neuron. Now when you stimulate this neuron, say, when you stimulate this neuron, okay, when you stimulate this neuron, what happens is, look, when you stimulate this neuron from minus 70, see, because of the stimulation, if the stimulation is powerful enough, okay, you are stimulating it. Because of the stimulation, if your stimulation is powerful enough, what happens is the membrane potential, the membrane voltage from minus 70, it is reaching to minus 55 millivolts because of the stimulation, whatever you are giving. Okay. Whenever it reaches minus 55 millivolts, look, whenever it reaches minus 55 millivolts, immediately on this cell, which channels are opening? Look, sodium channels opened. So sodium started to come into the cell. Sodium started to come into the cell. Okay, sodium came into the cell. So because of this, as the sodium positive ion is coming in, the membrane voltage from 55, okay, it will go to maybe plus 10 positivity. So this event is called as a depolarization. Okay, this event is called as what? Depolarization. So what is happening? Sir, initially it is at minus 70. Okay, when you stimulate it from minus 70, it is reaching to minus 50. Okay, here it is minus 70. Here it is minus 50. When minus 50 is reached, immediately which channels will open? Sodium channels will open. Because of that opening, the membrane voltage is going till towards positivity, plus 20 or plus 10. Okay. So this event is called as a depolarization. Depolarization. Once the depolarization is happening, look, once the depolarization happened, now what happens is on the cell, potassium channels open. Once the depolarization completed, potassium channels will open. So potassium will start to go out. Potassium will start to go out. When the potassium is going out, again as the positive charges are going out, again the voltage will come back to resting membrane potential. Again it is coming back to minus 70. Sometimes it even goes to, okay, it is getting minus 90. Sometimes it even goes to minus 90 millivolts. But again, because of the sodium potassium ATPases, again it comes back to normal. Again it's coming back to normal. Okay, so this is the action potential. So what is happening in the action potential? Simple. Let's go one by one. First step, resting. When the neuron is resting, it is having a voltage of minus 70 millivolts. It is sleeping. When you stimulate that neuron, okay, if you are giving stimulation, if your stimulation is powerful enough, that will take the membrane voltage from minus 70 to minus 55. Once minus 55 is attained, the voltage gated sodium channels are open. Voltage gated sodium channels are open. So sodium will come into the cell. When sodium comes into the cell, there is a depolarization. Once the depolarization completed, now later there will be first repolarization. Sometimes the membrane voltage can even go a little bit more negative. That is called as a hyperpolarization. Sometimes a neuron can undergo hyperpolarization. But again, it will come back to resting membrane potential. Question is, sir, see, when the sodium comes into the cell, do you think the same sodium will stay here? No. The sodium, okay, the sodium ions, they will also go to the surrounding. Region. So here it is how much in the beginning? How much is here? Minus 70 millivolts. Because of the sodium, see, the minus 70 will go to minus 55. When minus 55 millivolts is attained, now here also sodium channels are opened. So sodium will start to come into the cell. So that will lead to depolarization. Plus 20. Now this sodium, whatever have came, it will go to the surrounding area. Okay, it can go through the cytoplasm. It will go into the surrounding area. So because of the sodium, now in this region also, from minus 70 millivolts, it will reach to, because of the positivity, it will reach to minus 55 millivolts. Okay, so here also again depolarization. So depolarization is happening, means the electrical impulse, see these ions, okay, are traveling. So that is leading to the electricity. That electricity is passing through the nerves. Okay, so this is what I want you to know. Action potential. In your exam, what they will ask you. Okay, let me show you the images directly. What they will ask you is, this is the action potential graph. They will ask you. What you should know for your exam is, see, what is the resting membrane potential? Minus 70 millivolts resting membrane potential. You are stimulating it, light stimulation. You have stimulated light stimulation. Okay, light stimulation. It's not working. Okay, it's not working. Light stimulation. Now, when your stimulus is powerful enough, means from minus 70, that stimulus whatever you have given, it is bringing the resting membrane potential to threshold potential. See, okay. Now immediately what happens? Depolarization. The depolarization is because of influx of sodium. After depolarization, there is repolarization. Sometimes what can happen? There can be hyperpolarization. Now you are coming back to resting state. Repolarization is due to potassium efflux. Depolarization is sodium influx. So how many stages are there? Let me write one by one stages. This is the question. Write one by one stages. First stage, just give me a second. First is called as a phase 1. This one, phase 1. Phase 1. So what is phase 1? Phase 1, okay, during phase 1, the resting membrane potential is reaching the threshold. Okay, that is from minus 70 to minus 55 millivolts. That is the threshold. Okay, threshold. Now what is phase 2? Phase 2 in the action potential of a neuron. Now tell me, what is phase 2? See, here it is there, phase 2. Phase 2 is a depolarization in a neuron. MCQ. Phase 2. What is happening? Depolarization. Depolarization is dependent on sodium influx. Okay, sodium influx. After phase 2, what is there? So there is phase 3. Phase 3. That is because of what? Potassium efflux. Let me write here, phase 3. That is repolarization. That is also due to potassium efflux. Next, phase 4. Phase 4. What is phase 4? So the phase 4, look here, phase 4. This is the phase 4, sir. Below the resting membrane potential. Phase 4 is called as hyperpolarization. It is also because of potassium efflux. This is hyperpolarization because of potassium efflux. If you want to know one more thing, during hyperpolarization, what can happen is even chloride will come into the cell. Okay, even chloride will come into the cell. So if someone asks you, just know that one point, potassium efflux plus chloride influx. The last phase, again, you are coming back to normal. That is the resting membrane potential. So phase 5 is phase 5. That is resting membrane potential. That is again minus 70. So these are the 5 phases in the action potential of a neuron. These are the 5 phases. So direct question which was asked in the exam is phase 2 of action potential of a neuron. Phase 2 of the action potential of a neuron is depolarization, dependent on sodium. Phase 3 is repolarization, potassium efflux. Phase 4 is hyperpolarization due to potassium efflux as well as chloride influx. Phase 5 is resting membrane potential. Okay. See, for example, right now, you're all listening to the class. If you imagine you are a good student, okay, you are like Ram is a good boy, something like that. You are a good student, sir. Okay. Now, when you are a good student, when you are listening to the lecture, your friend is coming. Okay, when your friend is coming and asking, "Arey, why you are listening to all these lectures?" Okay, not need so 6 months is more than enough. No. So he's asking you to go for shopping. He's asking you to go for a mall, or he's asking you to go for a movie. So will you go? Tell me. Will you go? Tell me. No, you are not going to go because you are totally occupied. Okay, you are totally occupied. So what I want you to know is, sir, in this action potential duration also, okay, look carefully here. Look here carefully. So the nerve is generating the action potential, depolarization, repolarization. Starting from here, look, starting from here to almost, okay, to almost 1/3 of repolarization during this time from here till to here. During that time, you whatever you do to the nerve, you try to stimulate it again. You try to stimulate it. Like your friend is trying to ask you to go to the movie. Will you go? No. So during this time period, whatever you do, the nerve is not going to respond. The nerve is not going to generate one more action potential. The nerve is not going to generate a new action potential. That is called as absolute refractory period. So that's the image based question which will come up in your exam. So just wait. Let me clear these things. These are for your seniors. I have written. Get it? For your seniors also, see, these are the same things. Types of neurons. These are for your seniors. See, these are the phases of action potential. For last batch, I have taught all these things. So this one I want you to know now. Okay, these slides. So take this slide. Let me take this slide. Yeah, let me keep it here. So look, from here, Okay, from starting of the depolarization to actually 1/3 of repolarization. Actually, in this diagram it is here, but actually it should be here. But anyway, so this period which I am showing you in the color, okay, this is called as absolute refractory period. Okay, absolute refractory period, which means whatever you do to that neuron, it will not generate a new action potential. Okay, so let me write here. What is absolute refractory period? Okay, absolute refractory period. During this period, time, okay, during this period, how strong, how strong the stimulus you give, how strong the stimulus you give or we give, no important. Is generated during this time period. Okay, so now the class is happening, your friend is asking you to come, you won't go. But after some time, now we are at the end, right? Now we are at the end. Some students will feel like, our class is about to end. Okay, now let me go. Okay, I will watch the remaining video in the evening. So some students will be like that. So during this time period, see, okay, so what is this one? This is also repolarization. This is hyperpolarization and again normal. So during this time period where repolarization is happening, the last 2/3 of the repolarization and hyperpolarization, during this time, if you stimulate the neuron, it may generate an action potential. Okay, it may generate a new action potential. Okay, so what is that period? That is called as relative refractory period. Let me write here. Relative refractory period. What is this relative refractory period? Relative refractory period means if we give stronger stimulus than usual, means you need to give a little bit more stimulus. Okay, if you give stronger stimulus than usual, neuron can generate new action potential. Okay, during this period, yes, one more new action potential can be generated. Okay, that period is called as a relative refractory period. Okay, these are also questions which was tested previously. I am just telling you there are two types of refractory period. One is initial refractory, the initial period is called as absolute refractory period, and the second thing is called as a relative refractory period. During absolute refractory period, you do whatever you do, no new action potential is generated. During relative refractory period, if you give more stimulus, a new action potential can be generated. Okay, new action potential can be generated. So that is relative refractory period. Okay, done. So the last thing, sir, the last topic in the nerve physiology, which I want you to know for your exam, is this classification of nerve fibers. You already know it. Okay, you already know it. The last thing for today. Yeah. Classification of nerve fibers. In my body, there are neurons present, right? In my body, what are there? Neurons are present. Okay. In my body, neurons are there. See, I'm classifying the neurons. See, me and my girlfriend are there. Imagine me and my girlfriend. We are both scientists. Okay. Now, what we are doing is we are doing research on neurons. I'm classifying. In our body, neurons are there. Okay, let me classify these neurons into A, B, C types. Okay, A type of neurons, B type of neurons, and C type of neurons. A, B, and C. Based on what? Based on the amount of myelination. A have more myelination. A neurons have more myelination. B neurons have a little myelination. C neurons, they do not have any myelination. No myelination. So me as a scientist, what I'm doing, based on the amount of myelination, I'm doing the classification: A fiber, B fiber, C fiber. My girlfriend, She doesn't like, Arey, what is this ABC? Okay, are you a kid or what? Okay, are you going to kindergarten or what? No, this ABC are not good. So she is saying that let's classify, let's give names like 1, 2, 3, 4. Arey, at the end of the day, it's the same neurons. According to me, I'm calling them as A, she is calling them as 1. I'm calling them as B, she is calling them as 3. Okay, I'm calling them with the name C, she's calling them as 4. So it's the same thing, just to make the students confused, just to give the students more work. Okay, there are two different classification of neurons and nerve fibers. Nerve fibers are nothing but the neurons. Okay, there are two types of classification. Classification is based on what? Based on myelination. Based on what? Myelination. So according to this Erlanger and Glassy, okay, according to this Erlanger and Glassy, Erlanger and Glassy, there is A fiber, B fiber, C fiber. So what is A fiber, sir? You tell me. A fiber, sir. Right first. Highly myelinated. Highly myelinated. Who? A. C fiber, sir. Unmyelinated. Okay, C fibers are what? Unmyelinated. C fibers are unmyelinated. Okay, sir, done. And one more thing, one more difference which I want you to know. Sir, when you are moving from A to C, A fibers are like this. See, look, dekho. A fibers are like this. Means big diameter. A fibers are having big diameter. C type of neurons are having small diameter. So that's also one difference. Okay, that also one difference. So A fiber, let me write it here itself. Let me write it here itself. A fibers, they are having what? The A fibers are having maximum diameter. They are having maximum diameter. As they're having maximum diameter, okay, as they're having maximum diameter, they have fast speed of impulse conduction. Fast, they conduct the action potential fastly. They conduct the electrical impulse fastly. Okay, so velocity of impulse conduction. Okay, velocity of the impulse conduction is going to be maximum. With whom? A type of fibers. A type of fibers, because they are highly myelinated. They have highly myelination. So they can conduct the impulses very fastly. Okay. Done. That's the point which I want you to know. So that's the reason why, look, that's the reason why, look, when you are moving this arrow, concentrate on this arrow. When you are moving from A to C, A to C, when you are moving from A to C, what is decreasing? Diameter, velocity, and myelination decrease. Diameter, myelination, and velocity decrease. So C fibers are unmyelinated. They have less diameter. They have least velocity. Okay, least velocity of impulse conduction. They are all C. So done. Now, after this, according to me, I have said you, there are A fibers, B fibers, and C fibers. According to me, A, B, and C are there, right? Now I am further classifying. Okay, I am further classifying A into A alpha, A beta, A gamma, and A delta. A is further classified into A alpha, beta, gamma, delta. Okay. So in last class, I have taught you. Okay, in central nervous system, when I am doing the central nervous system, I have taught you. A beta fiber carries the touch. So those neurons which are carrying the touch, I call them as A beta. Okay, so they are highly myelinated. So A. Okay, those neurons which are carrying the touch information are called as A beta. Okay. In last class, I have explained you muscle. So those neurons which are causing the muscle contraction, are called as A alpha. Okay, A alpha. Those neurons which are causing the contraction of muscle spindle, I have said you muscle spindles, intrafusal fibers are innervated by the gamma motor neurons. So same gamma, look, same gamma. So those neurons which are innervating the muscle spindles are called as A gamma. Those neurons which are taking the fast pain sensation as well as cold, Okay, fast pain and cold sensations, those neurons, those highly myelinated neurons, look, those highly myelinated neurons which are carrying the fast pain as well as cold, I call them as A delta. A delta. Okay, so they will ask you simply, touch is carried by A beta, muscle spindles are innervated by A gamma, fast pain is carried by A delta, muscles are contracted by, okay, somatic motor. Somatic motor means voluntary muscle contraction. Those neurons which are causing the muscles to contract are A alpha. A alpha. Okay. And so those neurons which are doing the proprioceptive function. What is this proprioceptive function? Already I have explained you. From the muscle spindle. Muscle spindles are the receptors. Muscle spindles are the receptors. Muscle spindles, they always check the muscle length. They always check the muscle fiber length. Okay. And Golgi tendon organs, they check the tension on the tendons. They check the tension on the tendons. And they give this information where? They give this information to the central nervous system. They give this information to the central nervous system. So this proprioceptive information is going to the central nervous system. Via which fibers? In yesterday's class, you know, sir, class 1A fibers, group 1A fibers are innervating the muscle spindle, and group 1B fibers are innervating the Golgi tendon. According to the numerical classification, they are called as 1A and 1B. According to the Erlanger-Grassy classification, they are also coming under A alpha. A alpha. Okay, according to Erlanger-Grassy classification, they are A alpha. According to numerical classification, they are 1A and 1B. You understood? According to me, it is A alpha. According to my girlfriend, it is 1A and 1B. 1A is innervating muscle spindles. 1B is innervating Golgi tendon organs. Okay. So numerical classification is not that important. Okay, 2, 3, 4, these are not important. At least 1A, 1B, only these two are important. 1A is innervated by muscle spindles are innervating via 1A, and 1B is innervating the Golgi tendon organs. Okay. Next, sir, slow pain. I have discussed slow pain, visceral pain, dull pain, knee pain. It is carried by whom? It is carried by slow pain. Is carried by slow pain and hot temperature. Slow pain and hot temperature are carried by the C type of fibers. C fibers. Only remember these two things: slow pain and hot temperature. Okay. Slow pain and hot temperature are carried by C type of fibers. Now, finally, the last thing. Look at this. Okay. Okay. Just give me a minute. These things are like, first year things not needed. Now, look here. Now, this is your spinal cord, In anatomy, you will study, sir, the neurons which are coming out of the spinal cord. Right now, I'm talking about the sympathetic nervous system. Sympathetic nervous system. The neurons which are coming out, they will go to where first? They will go to the ganglion. So, these are called as preganglionic fibers. Preganglionic fibers. And the neuron which is going to come out, this is called as what? Postganglionic fibers. So, this is what I'm talking. So, the preganglionic fibers are B type, means because they are having at least little myelination. B fibers have little myelination. But the postganglionic sympathetic fibers, are C types, which means they are unmyelinated. So here myelination is not there. So this is C type. Here there is little myelination. So this is B type. Preganglionic sympathetic is B and postganglionic sympathetic is C. Okay, so you understood according to Erlanger-Grassy classification. So C fibers carry slow pain, hot temperature, and C fibers are also postganglionic sympathetic. B fibers are preganglionic sympathetic. So this is Erlanger-Grassy classification. Now let me ask you some questions. You just try to answer them. Okay, you just try to answer them. Okay, let me see. Sir, which fibers are having maximum diameter? Which fibers are having maximum diameter? See, answer. Which fibers are having maximum diameter? Maximum diameter. Which fibers are having highest speed of action potential conduction or impulse conduction? Which fibers conducts the action potentials with high velocity? Yes, Rahul, Sadish, Meena, you're all true. Rekha? Okay. So now tell me, sir, which fibers or which type of neurons are causing the contraction of muscle spindle. Contraction of muscle spindle. Contraction of muscle spindle. Otherwise, you're wrong. Rekha, you are wrong. Contraction, gamma motor neurons. Gamma motor neurons cause the contraction of muscle spindle. Are 1A, what is that? Sensory? No, 1A means proprioception. 1A means sensory supply. In yesterday's class, I have discussed muscle spindle have two supplies, sensory as well as motor. Motor supply is a gamma motor neuron. It causes the contraction of muscle spindle. It causes the contraction of intrafusal fiber. 1A, what is that? 1A is afferent. 1A is sensory. Okay, otherwise you understood. So that's the question. Who causes the contraction of muscle spindle? Gamma motor neurons. Who causes the contraction of the normal muscles? So somatic, like the skeletal muscles. Who causes the contraction of the normal skeletal muscles? Alpha. Okay, alpha motor neurons. Okay, alpha motor neurons. Alpha motor neurons. Sir, the preganglionic sympathetic neurons belongs to which category? According to Erlanger-Grassi classification, preganglionic sympathetic, it is B. It is B. Sir, cold sensation is carried by. Cold sensation is carried by C. Who is saying? Pawan, you are saying C, not C. It's A delta. Fast pain and cold are carried by neurons, or those neurons name is called as, simply called as delta, A delta. Okay, A delta. Okay, so Erlanger-Grassi classification completed. Okay, classification, Erlanger-Grassi classification completed. Okay, now integrated thing. I will teach you one integrated thing. If you give local anesthetics, right, there is a lot of controversy in this area, but trust me, follow this. Local anesthetics. Even in the online platform also, there is a little confusion, but trust me, this is like, authentic. Local anesthetics. If you use local anesthetics, what they will do? They will inhibit the neurons. They will inhibit the neuron firing. They will inhibit the impulse conduction so that you won't feel the pain. Local anesthetics is there. If you give local anesthetics, which fibers are first inhibited? Which neurons are first inhibited? A followed by B followed by C. Remember, first A fibers are going to be inhibited, followed by C, followed by C. Okay, so A fibers are highly sensitive. Sensitive to what? A fibers are highly sensitive to local anesthetics. First A both on the first A gone, later B gone, later C gone. If you want to know even in A, it is A gamma gone first. A gamma fibers are first inhibited, are highly sensitive to local anesthetics. Next, pressure. Okay, pressure. If you apply pressure, okay, for example, you keep your hand, okay, you keep your hand under your head and you sleep. Morning, you can't move the hand, sir. Okay, you can't move the hand. Okay, for a long time, you imagine you are sleeping with your girlfriend and your girlfriend is sleeping on your hand. Okay, she's keeping your hand as a pillow and she's sleeping. Okay, for her it is okay, but for you can't move your hand in the morning because your A alpha motor neurons are damaged with pressure. With the pressure, who is going to die first? Sorry. So A alpha fibers are damaged because of pressure, followed by B, followed by C. Same. A alpha followed by beta, followed by C. Next, hypoxia. This is simple, right? ABC, ABC, simple. ABC, ABC. Okay. Hypoxia. Sir, hypoxia is good or bad? Just tell me. When I was a student, I used to remember something like this. Hypoxia. Hypoxia is good or bad? Definitely bad. Do you welcome hypoxia? No, go back. Okay, hypoxia, go back. Something like that. Okay, so I used to remember back. Hypoxia means back. B followed by A followed by C. So B fibers are going to die first. Whenever there is hypoxia in the body, that kills the B fibers. B type of neurons are highly susceptible to hypoxia. Remember. Okay, you just look at this. I will show you the real question. Okay, then only you can understand how important these questions are. I will show you.
See, absolute refractory period. There are questions I will show you one by one. Very central nervous system. Yeah. See, this is the question which was asked. Which of the following has least conduction velocity? Which of the following has the least conduction velocity, guys? You know it. Sir, see the answers. Post-ganglionic sympathetic. You know, post-ganglionic sympathetic means C type of fibers. C type of fibers will be having least conduction velocity. That was the question which was asked in the FMG exam. Okay, that was the question which was asked in the FMG exam. Next question. Look at this. A person after sleeping with arm under his head now experiences paralysis. Paralysis means weakness in movement. He can't move the hand easily. But numbness is not there. He can feel the sensations. Which of the following is the best explanation? What is the best explanation? I wrote here. A fibers, especially A alpha fibers. A alpha fibers are highly susceptible. Okay. So A alpha fibers are more sensitive to pressure than C fibers. Okay, C fibers are functioning, but A fibers are gone. So such kind of questions can come up in your exam. So can you tell me what is this? Identify the type of transport shown here. Identify the type of transport shown here. Now, look. Just look at this. Sir, where the substances are moving, there is an arrow. You can clearly see the arrow. Sir, substances are moving from very high concentration to low concentration. So, energy is needed. No need of any energy because substances are moving from high concentration to low concentration. But who is helping? A protein is helping. A carrier protein, maybe a channel protein may be helping. So if the proteins are involved, what is that? Facilitated diffusion. Facilitated diffusion. Okay. I want to add the one thing. Okay, just by heart this one point. By heart this one point. Sir, absolute refractory period, tell me. Absolute refractory period. During this absolute refractory period, any new action potential is generated? No. No new action potential is generated due to the inactivation gates of voltage gated sodium channels. Okay, inactivation gates of voltage gated sodium channels are closed. Okay, so this is too much in detail. Like, you know, voltage gated sodium channels have an activation gate and an inactivation gate. Okay, there's too much in detail that will come in your first year, but not now. It's not needed for now. So if you want to know one thing, this is a question which was asked in the INICET exam. In INICET, this question was there. Because the inactivation gates are in closed state, a new action potential cannot be generated because the inactivation gates are closed. So sodium cannot enter into the cell. So new action potential cannot be generated. New depolarization cannot occur. Okay, remember this one point. Okay. So with this, important things. Let me show you that question also. I will show you that question also. This is like, you know, basic thing. DNA is present in mitochondria. Let me show you that question. Yeah, this one. Absolute refractory period. Look, the absolute refractory period. Anyway, I will teach this in rapid revision also. See, this is the voltage gated sodium channel. Okay, this is the voltage gated sodium channel. The voltage gated sodium channel. See, it is having an activation gate and inactivation gate. So this is the activation gate. This is the inactivation gate. Okay. During absolute refractory period, what happens is the inactivation gate is going to be closed. Okay, that is causing absolute refractory period is due to closure of inactive gates. I have also explained you this thing. See, try to answer this. A body fluid sample is being studied. Okay, you have given a body fluid sample. I gave you a body fluid sample. In that body fluid sample, sodium is 10 milliequivalents per liter. Sodium is 10 is there. Potassium is 140. See, so much potassium is there. If you see so much potassium, what is that fluid? Sir, potassium where potassium is more. Potassium is going to be more in intracellular fluids. It's an intracellular fluid. Sorry, intracellular fluid. In intracellular fluid, what do you have? More potassium. Extracellular fluid have more sodium. Extracellular fluids may who is more? Sodium is going to be more. Okay, sir. In the intracellular fluid, see in the intracellular fluid, how much? Who is very very less? Who is very very less? Sir, in the intracellular fluid, calcium. See 10 to the power of -4. Okay, very 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 less calcium is there when compared to outside. Okay, so done, sir. Our thing is done. Respiratory. Sorry. Now physiology also completed. Now let me share the PDF now itself. Okay, now let me share the PDF. This is for your seniors. I have taught this for seniors. See, for seniors also same things. Local anesthetics. Local anesthetics first. Okay, chalo. Now let me share this PDF now itself. So this PDF is all about nerve physiology and muscle physiology. So after this, sir, what is the leftover topic? In renal, I have a leftover. Okay, in renal, I said that I will be discussing the acid-base physiology after general physiology. Okay, so in the general physiology, I will be discussing the acid-base balance. So just wait for the 10 minutes. I will complete the topic so that we can say bye-bye. Okay, so now open the renal. Open your renal, sir. Let me make it as simple as possible for you. Okay, just 10 minutes is enough. What is your pH? Tell me. What is your pH? So pH, normal pH is 7.35 to 7.45. Okay, 7.35 to 7.45. It's the normal pH. And the pH should be always in this range. Okay, pH should be always in this range. Otherwise, okay, for example, what happens if the pH is less than 7.35? What happens if the pH is less than 7.35? That is called as acidosis. If the pH is more than 7.45, that is called as alkalosis. Why they are bad? Sir, in acidosis and alkalosis, in both these conditions, enzymes won't function. Enzymes stop functioning. If enzymes are stop functioning, you can't live, sir. Okay, if enzymes stop functioning, now the mitochondrial enzymes, the enzymes involved in the Krebs cycle, electron transport chain, they are not functioning. So what happened to the ATP? ATP production comes down. You will die. You will die, sir, actually. So we want the pH to be normal. If the pH is in this range, only then the enzymes are functioning. Okay, only then the enzymes will function. Okay, pH E range lo maintain avali. The pH should be maintained in this range. Otherwise, enzymes will not function. Okay, so enzymes stop functioning. What if pH changes? Enzymes stop functioning. Okay, the proteins, enzymes are the proteins. The proteins will undergo denaturation. The proteins will undergo shape change. So that automatically enzymes stop functioning. So pH is important or not? Yes, pH is very important, sir. So who is always maintaining the pH? If there is any acidosis or if there is any alkalosis, so immediately there should be someone who should correct it. Who will correct? So the first line of regulation, first line of defense here, first line of regulation in the maintenance of acid-base balance is buffer system. So second line of regulation is with the help of lungs. And third line of regulation is kidneys. So your buffers in the blood, lungs and kidneys, they will try to maintain the acid and bases in the normal range. Okay, having said that, first let's discuss about the buffers. Buffers, they act within seconds. If there is any change in pH, they act within seconds, sir, within seconds. Okay, what is this buffer? Buffers example is bicarbonate. Okay, the most important buffer which is there in your blood is your bicarbonate. What it will do, sir? Because of any reason, if there is acidosis in the body, already there is acidosis. Now, if there is acidosis, now do you know what this bicarbonate will do? Bicarbonate will immediately take this acid. Okay, this is the proton, this is the acid. Okay, it is responsible for the low pH. It is responsible for the low pH acidosis. So, whenever there is acidosis in your body, the bicarbonates, they will neutralize this acid. They will bind with that H plus, convert that H plus into H2CO3, and H2CO3 later it will be broken down with the help of carbonic anhydrase. With the help of this enzyme carbonic anhydrase, the HCO3 minus is splitting into water and carbon dioxide. Okay, so we have removed this proton, means you have converted this proton, you have neutralized this proton into water and carbon dioxide, so pH can become normal. Okay, so what is the most important buffer? Bicarbonate is the most important buffer. Most common buffer, MCQ asked. Is it intracellular buffer or extracellular buffer? It is extracellular. It's there outside the cell. It's there in the plasma. Extracellular means it's there where? It's there in the plasma. Okay. It's there in the plasma. Is there any intracellular buffer? Yes, we do even have intracellular buffers. So in your RBC, look, sir, the patient right now is having acidosis. Listen carefully, sir, here. The patient is having what? Acidosis. Draw this. Okay, acidosis. So the patient is having acidosis. Now, whenever the patient is having acidosis, see, this is your RBC. Inside your RBC, who is there? Hemoglobin. Hemoglobin have which amino acid? Histidine amino acid. See. Okay, this is histidine. Okay, here it is a histidine amino acid. Okay, now whenever the patient is having acidosis, now do you know what our RBCs will do? What our hemoglobin will do? It will immediately take these acids into the cell. H plus is the acid, right? So the H plus, it will be accepted by the histidine. So histidine is going to accept, is going to bind with the H plus. So now H plus is not there in the blood. H plus, it is not there in the blood. So what happened to the pH? Becomes normal, because see, now the H plus is now binding. Once it is binded, now it cannot contribute to pH. It is not responsible for pH because it is now in the bind form. It is there within the cell. It cannot contribute to the pH. Okay, so who is acting as an intracellular buffer? It's a protein, hemoglobin. Because of which amino acid? Histidine. And that's the question which was there in the FMG exam. Okay, just 1 year back, this is the question. So proteins can act as intracellular buffers. Okay, proteins can act as intracellular buffers. Which protein? Mainly hemoglobin. What this hemoglobin is doing? See, it is binding with the H plus. H plus is binding with which amino acid? Histidine. So amino acid in the hemoglobin, which is responsible for the buffer action, is histidine. Okay, so in our cells there is a buffer. And outside the cells also there is a buffer. Okay, intracellular buffer, extracellular buffer. Even in our urine also. Okay, urine. Our urine should also have a proper pH. Otherwise, stones will form. So even in our urine, there are buffers. Who are they? Phosphate in our urine can bind with the H plus, and ammonia in our urine can bind with the H plus, and they can act as a buffer. So MCQ, need PG. So what are the urinary buffers? Phosphate and ammonia, they are the urinary buffers. So buffer completed, buffer topic completed. So first line of regulation, they act within the seconds. What these buffers will do? Buffers, they will bind with the H plus, okay, and neutralizes the acid. So they can normalize the pH. Okay, understood? So tell me, guys, Is that clear? Buffers completed. If it buffers is completed, I will explain you about the second line of defense. That's the lungs. Okay, second line of defense. That's the lungs. Rekha, what is your doubt? Sir, can you explain my yesterday's doubt? What is your doubt? Myograms not needed. Rekha, if you have any doubt, ask me personally. Like, ask me personally in my WhatsApp. I will give you, personal, the answer, because other students will be like, WhatsApp, I send you, you send me the picture. Okay, I will explain you personally. Because Rekha, explain the topic. Cystometrogram, I have explained. No. Okay, let's see. Other students, let's start with other students. Students, in cystometrogram, I have explained you, right? What is the phase 1B? Phase 1B. Phase 1B in the cystometrogram. What is it? The bladder is stretching. That is plasticity. Rekha, that's the question you have asked in the question which you have sent to me from that FMG solutions. That's the same thing. Phase 1B represents plasticity. The bladder is stretching. Stretching is also called as a plasticity. The answer is plasticity. That's the question you have asked, Rekha, in yesterday's WhatsApp thing. Okay. Yeah. Array, that's the recent question. It's not there just in the FMG solution. That's the recent. That's a recent 20 days. That's not 20 days back. The recent question. Okay. The last FMG exam. Okay. Next. Okay. Chalo, let's talk about this. Lungs role in the maintenance of pH. Your lungs can maintain your pH. Okay. For example, don't write anything. First, don't write anything. Let me make a small change here. Okay. You don't write anything. Yeah. Let's go one by one. Okay, let's go one by one. See, imagine there is this one girl. Okay, let's take one girl. Now, this girl is crying. Okay, why she is crying? This is February month. Now, she is into relationship with one boy, and the boy is, and she's asking, buddy, could you please give me iPhone 15 Pro Max to me as a gift to this Valentine's Day, February 14th? Could you please give me the iPhone 15 Pro Max? And he's saying, okay, he's saying like, I can't even have money to feed myself. How I can give you iPhone 15 Pro Max? So she started crying. You know how girls cry. Okay, she's crying. Now, how girls cry? Like, she's not crying normally. She is like crying, like, doing hyperventilation. She's crying something like that. Okay, like a small, like, girl, she's crying. So now look, let's go one by one. What is she doing? She's doing hyperventilation. What she's doing, sir? Hyperventilation. Now she's crying something like that. Okay. Whenever she do hyperventilation, what happens? She is breathing more number of times. So carbon dioxide is going to go out of her body. Okay. Carbon dioxide is going to go out of her body. So carbon dioxide wash out. Okay. Carbon dioxide is going to wash out. Now, whenever carbon dioxide is going out, see, one thing you should know, one thing. Okay, sir, carbon dioxide is the source of acid. Okay, sir, carbon dioxide is what? Carbon dioxide. Sorry. Carbon dioxide, normal in your body, it reacts. Look, carbon dioxide, it reacts with water, forms carbonic acid. Carbonic acid. Okay, carbonic acid. And the carbonic acid, later on, it can be divided into H plus and HCO3 minus. See, this H plus, only H plus, not HCO3 minus. H plus determines your pH. H plus can bring down your pH. Okay. So what I'm trying to put in your mind, carbon dioxide is the source of acid. It's the source of acid. Some students will think, sir, even bicarbonate is getting produced or no, base is getting produced or no. Sir, bases are not responsible for the pH. Sir, it is the H plus ions. What is pH? pH is the logarithmic expression of H plus. Okay. So carbon dioxide can decrease your pH. Okay. Okay. But what I'm trying to put into your mind, see, now my female, she's crying. Okay. She's doing the hyperventilation. Whenever she's trying to do the hyperventilation, carbon dioxide goes out of the body. Whenever carbon dioxide goes out, what happens to the pH? Sir, pH decreases. Now, what she's having? Now she's having respiratory alkalosis. Now her pH is, sorry, not pH is going down. Sorry. pH is going to increase, right? Sorry, I forgot. Sorry, I made a mistake. pH increases because, sorry. Now here, carbon dioxide is going out. Carbon dioxide is going out means acid production decreases. When acid levels decreases, pH increases. When acid levels decreases, pH increases. More pH means alkalosis. So because of the respiratory problem. So because of the respiratory problem, now because of the respiration, she's having respiratory alkalosis. So at the end of the day, what I'm trying to put into your mind, sir, what I'm trying to put into your mind is, sir, your lungs, the way you breathe can influence the pH. Aha, okay. The way you breathe can influence the pH. The way you breathe can influence your pH. So that's why in Indian culture, we say like, morning. Okay, when you wake up. Okay, let me tell you one by one. Let's go one by one. For example, see, sir, when you sleeping, when you are sleeping, today night, when you are sleeping, what happened to your respiration? Your respiration decreases. So you will do, say, sleeping. Let's write one by one. Sleeping. When you sleep, what happened to your respiration? Respiration decreases. So that is hypoventilation. Okay, hypoventilation. When you do hypoventilation, carbon dioxide is accumulating in your body. Carbon dioxide reacts with the water and forms acid. So when you sleep, actually, there is acidosis. When you sleep, what happens to your body? There is acidosis. Okay, when you sleep, there is respiratory acidosis. When you sleep, there is respiratory acidosis. So our ancestors know that whenever you are sleeping, there can be acidosis environment in your body. So in the morning, what they will ask you to do? Morning, they will ask you to do meditation and yoga. So in meditation and yoga, what we do? Concentrate on breathing. Meditation is all about concentration on your breathing. So meditation, deep inspiration, deep expiration. Deep inspiration, deep expiration. So look, whenever you do yoga, for example, say whenever you do yoga or meditation, what you will do? You will do hyperventilation, sir. You will do hyperventilation. When you do hyperventilation, just now I have explained you, when you do properly, when you do hyperventilation in the morning properly, that will do what? Carbon dioxide wash out. Okay, that will do carbon dioxide wash out. Not too much. Properly, when you do meditation or yoga, that will cause that you are removing the carbon dioxide out of the body. When you are removing the carbon dioxide out of the body, what happened to the acids produced during the night? Acidosis decreases. The acid production in the body decreases. The amount of new acids that are producing in the acid decreases. The pH will become normal. So at the end of the day, buddies, the only point which I want you to know is, sir, the way you breathe can change your pH. So breathing is very important. The way you breathe can change your pH, sir. Okay, so lungs, they can balance the pH. True. Okay, so for example, see, when if the patient is having acidosis, patient is having acidosis, do you know what this acidosis will do? Sir, acidosis can lead to, see, diabetic ketoacidosis. You know the case I have explained. Diabetic ketoacidosis, the patient is having acidosis. Whenever there is acidosis, the patient, what he will do? The patient will do hyperventilation. He will do hyperventilation. Whenever he do hyperventilation, carbon dioxide goes out of the body. Carbon dioxide levels decreases. So acid levels decreases. Okay, so pH will become to normal. Okay, pH will try to come back to normal. So lungs will try to maintain the pH. That's it. Okay, lungs will try to maintain the pH. So you understood? So buffers will try to maintain the pH. Your lungs will also try to maintain the pH. Is that clear? If it is clear, the last thing, the kidneys, the last regulatory point, kidneys. Last regulatory point, kidneys, I will explain, and I will close the subject. Kidneys role in the pH balance. Okay, what your kidneys will do? That's a third control, means it takes a lot of time for kidneys. Look, whenever you are having acidosis, okay, if you have acidosis, look, tell me, do you want acids? Do you want any new acid production in the body? No, already you are having acidosis. 7.35, less than 7.35. You are already having what? Acidosis. Now, during this time, see what your body is doing. Protons are excreted. Okay. Your kidneys are kicking the protons out of the body. Okay. Your kidneys are throwing the acids out of the body. Okay. And at the same time, your kidneys are generating these buffers. Look, your kidney is generating bicarbonate. Okay. Okay. Your kidneys are reabsorbing more bicarbonates. So these three events, if I teach you, that is completed. The topic will be completed. Whenever there is acidosis, you think, okay, whenever the patient is having acidosis, we don't want the acids. So the H plus, the acids need to be excreted. We need to excrete the acids. And not only that, you have to reabsorb the bicarbonates. Reabsorb bicarbonates. And not only reabsorbing the bicarbonates, your kidneys also have an ability to generate new bicarbonate. That's it. So these three I'm going to explain you now. So first, let's talk about the bicarbonate reabsorption. Now I'm going to discuss how bicarbonates are reabsorbed in your kidneys. How? MCQ, important. Now, rather than showing you in this diagram, I will make my own diagram so that it will be easy for you. Okay. Sir, this is the PCT. Imagine this is your PCT. Here is the woman's capsule on the top. This is the PCT, epithelial cell. Okay, there is a brush border, but I am not showing the brush border. Just leave it. Here there is peritubular capillary. Okay, here is a peritubular capillary. Now, bicarbonates, already in your body, bicarbonates are there. HCO3 minus. You are supposed to reabsorb the bicarbonate. We are not supposed to leave the bicarbonate. You have to reabsorb this bicarbonate. How can we reabsorb this bicarbonate, HCO3 minus? See, the reabsorbs cannot go into the cell because they are having negative charge. You can't take this into the cell. So what happens is, look, this PCT epithelial cell, it is throwing one proton. See, it is throwing one proton into the urine. Okay, this is the one proton. Look carefully here. It's throwing what? One proton in exchange for sodium. Okay, in exchange for sodium. Okay. Now, this proton is going to be fused with the HCO3 minus. So, HCO3 minus is going to fuse with the proton. So, H, here one H. So, H2CO3, it becomes H2CO3. Okay, H2CO3. Now, this H2CO3 is going to split into. It's going to split into with the help of enzyme called as carbonic anhydrase. H2O and CO2. H2O and CO2. Okay. Now, this H2O will come back into the cell because water is reabsorbed as well as carbon dioxide. It also lipid soluble. Carbon dioxide is also lipid soluble. It will also coming into the cell. So now what we have done is simply we have converted this bicarbonate. We have converted this bicarbonate into water and carbon dioxide. Okay. Okay. Water and carbon dioxide. Okay. Now we are reabsorbing this water and carbon dioxide. H2O plus carbon dioxide came into the cell. Now in the cell, reverse is happening. Reverse reaction. Now again H2O, CO2. Again they will fuse and form H2CO3. Okay. H2CO3. Now this H2CO3 is going to split into H plus. Now it's going to split into H plus and HCO3 minus. Shouldn't. So the HCO3 minus, which was supposed to be here, ultimately came into the cell. HCO3 minus came into the cell. So this HCO3 minus is reabsorbed back into the blood. So you have reabsorbed the bicarbonate. Okay. Again this H plus. Look, again this H plus will again go into the lumen. Again it will go into the lumen. So the same H plus is rotating over there. The same H plus is circling over there. Okay. So that's it. Bicarbonate reabsorption completed. So let's see the same thing here. This cell, PCT epithelial cell, it is throwing. Okay. It is throwing what? One H plus. The bicarbonate is going to fuse with the H plus, converted into H2CO3. Now with the help of enzyme, carbonic anhydrase, H2O and CO2 are forming. It's getting split. H2CO3 is getting split into H2O and CO2. I have explained. CO2 plus H2O, again they will fuse back to H2CO3 and bicarbonate is reabsorbed. Okay, bicarbonate is reabsorbed. Now, what are the questions they will ask you? See, the same H plus is again going back. See, the same H plus is again going back. So, what is the net proton secretion? Same proton, there it is rotating. So, what is the net secretion of proton? 0. So, proton is secreted in PCT. True, right? Proton is secreted. See, here proton is getting secreted from the PCT epithelial cell. What is the net secretion? 0, because it's same rotating. So nothing is getting excreted. So net proton secretion is 0 because it's the same thing again reabsorbed. Next question. Sir, bicarbonates, HCO3 minus C, bicarbonates are reabsorbed. Where? In PCT. How much percent? Almost 80%. With the help of which transporter? What is the transporter that is helping? So this transporter, sir, MCQ which was asked, that is sodium proton exchanger. With the help of sodium proton exchanger, the bicarbonates are reabsorbed. Okay, so that's the question. Sodium proton exchanger question. Neat PG question. Sodium proton exchanger is present on the PCT. It secretes the protons and helps in the reabsorption of bicarbonate. It helps in the reabsorption of bicarbonate. Okay, done. So one thing completed. So far, what we have completed? One thing is completed. What is that one thing? This is completed. How bicarbonates are reabsorbed? We have completed. Okay. Next, let's see how new bicarbonate is generated in the time of need, in the time of acidosis. You can generate, your kidneys can generate a new bicarbonate. Not reabsorbing. We are newly synthesizing the bicarbonate. How it occurs, sir? Look at here. So again, this is PCT. See, heading. Okay, generation of bicarbonate in the PCT. In how many ways it is generated? In how many ways? There are 2 ways you can generate the bicarbonates. Let's make it as simple as possible. Now, whenever the patient is having acidosis, look, now in the PCT cells, what is happening? Again, I'm telling you, I'm not reabsorbing. Now the PCT cell, it have its own. See, PCT cells are breathing or not? Tell me. PCT cells, they use oxygen and produce carbon dioxide. So this is that carbon dioxide. Okay. So PCT cells, they are producing the carbon dioxide. True. And in the PCT cells, there is cytoplasm. So water is there. So water is going to be fused with the carbon dioxide, forms H2CO3. H2CO3 will split with the help of carbonic anhydrase. H2CO3 will split into H plus and bicarbonate. Look, now a new bicarbonate is generated. Okay, not reabsorbed. It is not reabsorbed. It is newly generated within the cell. And one proton is also generated. We don't want the acid now. We don't want the acid. So that acid is kicked into the urine. Okay, that acid is kicked into the urine and it will be lost in the urine. So you have generated a bicarbonate. Now you will reabsorb the bicarbonate. Okay. So this is one way. This is one way. What is the other way to reabsorb the, what is the other way to generate the bicarbonate? See, the other way is whenever there is a need, again, acidosis. Acidosis, hey, whenever there is acidosis. Now this PCT epithelial cell, they will break this thing called as the glutamine. So the glutamine is going to be metabolized, will be broken down. When the glutamine is broken down, 2 bicarbonates are generated. Okay, 2 bicarbonate, 2 HCO3 minus 2 bicarbonates are generated. Okay, 2 bicarbonates are generated. So this is the question. Metabolism of glutamine will yield. It will yield 2 bicarbonates during acidosis. So done, sir. New bicarbonates are also generated. Okay, so this is also completed. So de novo synthesis, bicarbonates. How bicarbonates are generated? By breakdown of glutamine as well as by mixing carbon dioxide and water. So these 2 things completed. The last thing is how H plus is excreted. The last thing for today, how H plus is excreted. Okay, look at this slide. Look at this slide. Now, right now I'm not talking about the PCT. Right now I'm not talking about the PCT. I'm talking about the intercalated cell. Okay, I'm talking about what? Intercalated cell. Now, intercalated cells, when they are acted upon by aldosterone, it. Intercalated cells, what they do? Sir, whenever there is acidosis in the body, look, here I'm showing you. two things, two conditions I am showing you, acidosis and alkalosis. First, let's concentrate on this side, acidosis. So this is where urine is coming, urine, this is the side of the urine here. Now, whenever there is acidosis, we don't want the acid. So the intercalated cell, see what it is doing? It is kicking the acid out of the body. That's it. It is kicking the acid out of the body. Okay. Okay, it's kicking what? Acid out of the body. That's it. And whenever there is alkalosis, okay, whenever there is alkalosis, the same intercalated cell, see what it is doing. The same intercalated cell, what it is throwing into the urine. Now this side, this side is the urine side. Okay, now I'm showing the urine this side. Now, whenever there is alkalosis, it is kicking the bicarbonate out of the body. Okay, it is kicking what? Bicarbonates out of the body. Aha, okay. So intercalated cell is like your girlfriend. Sometimes she behave differently, sometimes she behave differently. Okay, her behavior is going to change according to the situation, but she's a good girl. Finally, she's a good girl. Okay, so she's doing what she have to do. She's doing what she have to do. So whenever there is acidosis, the intercalated cells, they will throw the acids out. When there is alkalosis, the same intercalated cell, they will throw the bases out, bases into the urine. So the behavior of the intercalated cell is changing. The behavior of the intercalated cell is changing. So what I want you to know is, during acidosis, what kind of intercalated cell you are having? Sir, during acidosis, you are having alpha intercalated cells. What are alpha intercalated cells? Are A for A. During acidosis, you have alpha intercalated cells. These alpha intercalated cells, they excrete what? Acid. Alpha for acid excreting. They go. Acids are getting excreted. During alkalosis, you have same intercalated cell, but this intercalated cell is called as beta intercalated cells. It's the same intercalated cell. Why we are calling it as a beta intercalated cell? Because it excretes bases. Beta for base, alpha for acid. So alpha intercalated cells are acid excreting cells. Beta intercalated cells are base excreting cells. So the question which will come up in your exam is, alpha intercalated cells are seen during acidosis. Alpha intercalated cells are acid excreting. So alpha will change to beta. Beta can change to alpha. This is INICT question. Alpha intercalated cell, it can change into beta. Beta intercalated cell can change into alpha. This change is mediated by, with the help of a protein called as hensin. Need PG. Hensin. Dekho here. Hensin mediates the adaptation. So this is also completed. So how acids are excreted? Topic completed, sir. How acids are excreted? Via intercalated cell. Okay, which type of intercalated cell? Alpha intercalated cells. So this thing completed. So acid base balance also completed. Next, one slide, the last one slide is anion gap. So what is this anion gap? Okay, what is this anion gap? Milli equivalents per liter anion gap. Now let me tell you one thing. Sir, in your body, the number of positive charges, that is sodium, potassium, positive charges, the number of positive charges and the number of negative charges are equal. Okay, if there are 100 positive charges, there are 100 negative charges. It is equal. Okay, so let's see that in the form of a formula. So let's see the formula for the anion gap. The formula for the anion gap is, let me write here in a big letters, important formula. Sodium, the positive charges in the body are represented with sodium. The major positive charge in the body is sodium. Let's take positive charges as sodium. Sodium minus means positive charges minus negative charges. What are the negative charges? The two major negative charges in the body are, HCO3 minus one negative charge plus chloride is the other major negative charge. So let's see what is the difference. Sodium concentration is 140. So 140 minus, how much bicarbonates are there? Bicarbonate concentration is 25. And how much is chlorine? Chlorine is 105. So 140 minus, how much? 25 plus 105? 130. Okay, 130. So how much difference is coming? I said in the beginning, the number of positive charges should be equal to the number of negative charges. But here it is coming that negative charges are less. Negative charges are less. How much less? 10 milli equivalents per liter. There is a gap. Negative charges are less. So that is called as anion gap. Okay. But in reality, the number of positive charges and the number of negative charges should be equal. But why it is showing that there is less negative charges? Why there is this anion gap? First question number 1 is, what is the anion gap? 10 milliequivalents per liter, but the range can be from 8 to 16. The anion gap range can be from 8 to 16. That is normal. Normal anion gap is 8 to 16. That gap can be, the difference can be 8 to 16. But why? Why you can't, why the negative charges are less? Because you cannot measure certain negative charges in the body. Certain negative charges, you can't measure them. Okay, there are negative charges in the body, but you can't measure them. What are they? See, that anion gap is coming due to the unmeasured negative charges, unmeasured anions. What are they? Unmeasured anions are plasma proteins. They are negative, sir. Plasma proteins are negative, but you can't measure their negativity. You can't measure their negative charge. Lactates are there in the body, which are negative. You can't measure them. Keto acids are there. You can't measure them. So, because you cannot measure, okay, because you cannot measure these negative charges, it is showing that there is anion gap. Okay, that answer me. What is the normal anion gap? 8 to 16 milliequivalents per liter. Okay, 8 to 16 milliequivalents per liter. That anion gap is due to unmeasured anions. What are they? Plasma proteins, lactate, and keto acids. Now, for example, you can't measure them, right? You can't measure these things. Okay, but for example, if you have more keto acid production in your body, more lactic acid production in your body, so what happened to the anion gap? Automatically gap will also increase. Okay, so the point which I want you to know is, sir, if the patient is having metabolic acidosis, see, acidosis, that metabolic acidosis is of two types: high anion gap metabolic acidosis, okay, high anion gap acidosis, okay, and normal anion gap metabolic acidosis. Okay, high anion gap metabolic acidosis or normal anion gap metabolic acidosis. So metabolic acidosis are any rakalu? How many types of metabolic acidosis are there? There are two types of metabolic acidosis, sir. High anion gap. See, when you will have high anion gap metabolic acidosis, see, you know it already, sir, in the patients of DKA, diabetic keto acids, see, keto acids, if keto acids are increasing, the anion gap will also increase. Lactic acidosis, if lactic acid is increasing, you can't measure it. So gap will also be more, high anion gap. Sir, salicylate poisoning. Okay, salicylate poisoning. These are also negative charges. You can't measure it. So that will increase the anion gap. So in your exam, the super high yielding point is, sir, DKA and lactic acidosis. Just by heart it. Just by heart it before going to the exam. Okay, your 5th year is also complete before going to the exam. So you need to know certain by hearting things. Sir, DKA, anion gap increases because the keto acids are increasing. Lactic acidosis, high anion gap. Salicylate poisoning, high anion gap. Okay, high anion gap, metabolic acidosis. See, already here acidosis is there. Okay, salicylates are acids. It will cause acidosis. But high anion gap metabolic acidosis. In which conditions you will have normal anion gap? The patient is suffering with acidosis, but the anion gap is normal. Diarrhea, vomiting. Okay, vomiting. This is RTA. Okay, renal tubular acidosis, put 5-star marks. Renal tubular acidosis. Okay, hypoaldosteronism. Okay, hypoaldosteronism. Because you know the story. Are aldosterone ledu. Hypoaldosteronism. Aldosterone nahi hai. Aldosterone nahi hai to normally aldosterone what it will do? Sir, look, aldosterone kicks, throws the acid out of the body. Aldosterone helps in sodium reabsorption, potassium and proton excretion. Aldosterone causes potassium and proton, see, proton excretion. So when aldosterone is not there, protons are not excreted. That's the same thing. Hypoaldosteronism, proton concentration in the body increases. So that will cause what? Acidosis. That will cause acidosis. So hypoaldosteronism causes acidosis. That is called as renal tubular acidosis type 4 MCQ. What is renal tubular acidosis type 4? Renal tubular acidosis type 4. It will come in your medicine. Renal tubular acidosis type 4 means aldosterone is not there. When aldosterone is not there, protons are not excreted. When protons are not excreted, that will cause acidosis. Which type of acidosis? Normal anion gap acidosis. So renal tubular acidosis is an example of, see here also I have written, renal tubular acidosis is an example of normal anion gap acidosis. So with this, topic is completed, sir. Now question C, anion gap, normal, 8 to 16 milliequivalents per liter. Anion gap is due to unmeasured anions. What are those unmeasured anions? Plasma proteins, lactates, keto acids. So whenever the patient is having diabetic ketoacidosis, lactic acidosis, the patient is going to have high anion gap metabolic acidosis, and diarrhea, RTA, or hypoaldosteronism can lead to normal anion gap metabolic acidosis. Okay, so with this, our thing is completed, sir. Okay, Becca, I will explain you personally how to identify metabolic or respiratory. That will come in your medicine. But if you want to see, Rahul Singh is Rahul Singh is asking one question. Okay, let me give you one question, sir. Whether it is metabolic acidosis or respiratory acidosis, how to check? Let me give you one question, sir. Let me give you one question. Rahul, okay, special for Rahul. Look, Rahul. Now I'm giving, there is a patient. Our patient is Rahul. Oh, Rahul is our patient. You have to tell me what is happening in the Rahul. So the Rahul's pH is, I'm giving 7.2. Rahul pH is how much? 7.2. Okay, first let me tell you what is the normal value. What is the normal pH, sir? Right here, three things. Normal 7.35 to 7.45. This is normal. What is the normal carbon dioxide levels in the body? Right. Normal carbon dioxide levels in the body is 40 to 45. Okay, 40 to 45, normal. Partial pressure of carbon dioxide in the body is normal, 40 to 45. HCO3 minus 22 to 26 milli equivalents per liter. This is normal. Normal values. Any problem with the carbon dioxide? Look, if carbon dioxide is increasing, that will be called as a respiratory problem. If bicarbonates are increasing, look, okay, if bicarbonates are increasing, that is called as a metabolic problem. Okay, bicarbonates, I'm talking about metabolic thing. Carbon dioxide, I will be talking about respiratory. Carbon dioxide is the function of your respiratory system. Bicarbonate production, bicarbonate reabsorption is a function of your kidneys. That is your metabolic function. Okay. Now, Rahul, let's come to the Rahul case. Rahul pH is 7.2. His carbon dioxide levels in the body is 55. His bicarbonate levels in the body is 25 milli equivalents per liter. Now tell me, he is having acidosis or alkalosis? First check. He is having acidosis or alkalosis? Sir, 7.2. So definitely he is having what? Acidosis. Okay. Now check the carbon dioxide levels. Sir, carbon dioxide is more. Sir, carbon dioxide is more. Understood? Sir, more carbon dioxide means more acid generation. You know it. More carbon dioxide means more acid generation. So this is what? Respiratory acidosis. This is respiratory acidosis. Because bicarbonates under normal range. Okay. So this is respiratory acidosis. The patient is having more carbon dioxide. This is respiratory acidosis. Okay. Okay. Now, let me give you one more question. So same Rahul. Okay, our patient is again Rahul. Now his pH, how much is his pH? 7.2 again. His partial pressure of carbon dioxide is a 40 mm Hg, 40 mm Hg. His bicarbonate levels are 20 milli equivalents per liter. Now tell me, sir, he's acidosis or alkalosis? Acidosis. Check pH, acidosis is there. Now, is it respiratory? No, carbon dioxide is normal. But why he is having acidosis? Why he is having acidosis? Because bicarbonates are going down. His bases are decreasing. Sir, look, his bases are decreasing. Okay, so his base levels, his alkali levels are going down. So relatively, he is having acidosis. So this is example of metabolic acidosis. You understood? So Rahul, I hope you understood. Okay, you will study this again in your medicine also, where you will study a little bit more compensated, decompensated things. Okay. So Harish is asking, should I have to explain about that compensation, decompensation? Should I have to explain about compensation, decompensation? Okay, see, just 1 minute. Let me give you one more case. Okay, let me give you one more case. Look, the pH, again, the patient is Rahul. Patient is Rahul. Rahul, the pH is, Rahul's pH is 7.2 now. Okay, 7.2 now. Now, his PCO2, look, his PCO2 is, let's say his PCO2 is, let me give you 55 mmHg. Okay, he's having 55 mmHg, and his bicarbonates HCO3 minus, his CO3 minus, his HCO3 minus is 35 sorry, not milliequivalents per liter. Milliequivalents per liter. Now tell me, sir, first of all, right, acidosis or alkalosis? Acidosis. So definitely acidosis. Okay, but look the carbon dioxide levels, more carbon dioxide levels. Look at the bicarbonate levels. Bicarbonate levels are also more. So is it respiratory or is it metabolic? Sir, both are increasing. Both are increasing. Is it respiratory or is it metabolic acidosis? Sir, definitely this is respiratory acidosis, sir. Respiratory, because carbon dioxide is increasing. Now students will say, sir, bicarbonates are also increasing. No, why not we say metabolic acidosis? Array, bicarbonate, if bicarbonate increases, it will cause alkalosis, not acidosis. So this is a case of, again, respiratory acidosis. But why bicarbonates are increasing? Why bicarbonates are increasing? Sir, in the body, acids are increasing, acidosis. So his kidneys are trying to produce more bicarbonates, trying to compensate. His kidneys are trying to compensate. Okay, so respiratory acidosis, but is his kidney successful? Okay, are his kidneys successful in bringing the pH back to normal? No, his kidneys are trying to compensate, but not completely compensated, but because still the patient is having acidosis. Okay, so this is respiratory acidosis, not compensated. His kidneys are trying, but not, the pH not came to normal. Okay, the pH didn't came to normal. So respiratory acidosis is there. The respiratory acidosis is there, but his kidneys are trying, but not completely compensated, partially compensated. Okay, because bicarbonates are increasing, means partially the kidneys are trying to bring the pH back to normal, but completely not, the pH is not coming back to normal. Okay, so partially compensated. Now let me give you one more question so that you will have a better understanding. See, same Rahul, our patient is Rahul. His pH, okay, his pH is now 7 point, okay, for example 7.32, okay, 7.32, okay, almost like, no, let's say 7.35 only. Okay, let's say he's having 7.35, okay, 7.35. The pH is normal. See, the pH is normal. Now look at the carbon dioxide and look at the bicarbonates, HCO3 minus. Now carbon dioxide levels are 50. Carbon dioxide levels are 50 mmHg. Bicarbonate levels are maybe 32 milliequivalents per liter. Okay, sir, see, carbon dioxide is increased, sir. There is so much carbon dioxide. See, there is so much carbon dioxide that increases acid production, that will cause acidosis. So the patient is having acidosis, but pH is normal. Look, why pH is normal? So the patient is having acidosis because of respiratory problem. So respiratory acidosis is there, but bicarbonates, the kidney is trying to increase the bicarbonates, so the pH came back to normal. So completely compensated. Respiratory acidosis, completely compensated. Okay, completely compensated. Okay, because bicarbonates are increased. Okay, acids are increased. So same amount of bicarbonates are increased, bringing the pH back to normal. 7.35 is normal. So completely equalized. Okay, the patient had respiratory acidosis. See, more carbon dioxide is there, more acid is getting produced. So respiratory acidosis is there, but it is completely compensated. Okay, so this will, again, you will study this in your medicine also. Okay, so I hope you have a clarity. Okay, let me ask you one more question. Let me give you one more question. You just try to answer it. Sir, the pH of the patient is 7.6. PCO2 is PCO2 is, let's say, 30, and bicarbonates. Okay, bicarbonates are how much? The bicarbonates are, let's say, 25. Okay, bicarbonates are 25 milli equivalents per liter. Carbon dioxide is 30 mmHg. Now tell me, first of all, the patient is having what? Alkalosis. Alkalosis. Why there is this alkalosis? Sir, his carbon dioxide levels are going down, which means acid production is decreasing. Acids are not getting produced properly. So respiratory problem. So this is respiratory alkalosis. Respiratory alkalosis. Bicarbonates are normal. Bicarbonates are in normal range. So this is respiratory alkalosis. Is it compensated? No compensated. Not compensated. Not even partially compensated. This is pH is not coming back to normal. So not compensated. Not compensated. Respiratory alkalosis. The patient is having respiratory alkalosis, which is not compensated because you know the stuff. pH is not coming back to normal. Okay. Is that clear, guys? Is that clear, guys? Okay. With this, our physiology is completed. We'll see you again. We'll see you again during test and discussion and rapid revision. Okay. We'll see you again during test and discussion and rapid revision. Again, I'm telling you, don't hesitate. If you have any doubts, always message me personally. Okay. Maybe I will give you late response. Okay, but I will surely give you response. Okay. Bye-bye, guys. See you. Hope these classes help you. Okay. Hope you understood. You just stick to the material. You just stick to the material. You can clear all the MCQs from physiology. Okay. Bye-bye. Bye-bye, guys. Bye-bye.